Yeah, live.
A very good evening, everyone. Welcome to today's webinar, hosted by All India Ophthalmological Society, where we delve into the critical topic of managing a walk-in child with leucocoria. Leucocoria, often an alarming clinical sign, can be the first indication of a myriad of diagnoses, ranging all the way from benign lesions like Coats disease to potentially life or vision-threatening conditions, including retinoblastoma. In this session, we will discuss a standard structured approach to diagnosing, triaging, and managing such cases, emphasizing on the importance of early detection, timely intervention, and multidisciplinary care. With insights tailored for ophthalmologists across all subspecialties, this webinar aims to equip you with practical strategies to navigate these complex scenarios and ensure optimal outcomes for your young patients. So let's get started. And I thank the AIOS dignitaries for coming up with the whole concept of walk-in series. And thank you so much for organizing the sessions. Dr. Partha Biswasa, our president, Dr. Santosh Unavasa, our honorary general secretary, Dr. Manoj Chandra Mathur, sir, our honorary treasurer. And I also thank our chairpersons for the session today, Dr. Partha Biswas sir, Dr. Lingam Gopal sir from Shankar Nethralaya, Chennai, Dr. Mahesh Shanmugam sir from Shankar Eye Hospital, and our moderators for the session today, Dr. Santosh Unavas sir from Center for Sight, Hyderabad, Dr. Manoj Mathur sir from Sarup Eye Center Medivision, Hyderabad, and Dr. Ishita Rungta and myself from Mahatma Gandhi Medical College, Jaipur. Our panelists for the session today are Dr. Divyansh Mishra sir from Shankara Eye Hospital, Bangalore, Dr. Feroz ma'am from Horace Subspeciality Eye Care, Bangalore, and Dr. Mangad Dogra sir from Grewal Eye Institute, Chandigarh, Dr. Pratham Datta Majumdar sir from Shankara Nethralaya, Chennai, Dr. Seema Das ma'am from Dr. Shroff Charity Eye Hospital, New Delhi, Dr. Sumit Lahani sir from Raghunath Nethralaya, Mumbai, Dr. Sushma Jayana ma'am from Narayana Nethralaya, Bangalore. Our presenters for this session are Dr. Anureet Kaur from Dr. Shroff Charity Eye Hospital, New Delhi, Dr. Ashwita Alva from Center for Sight, Hyderabad, Dr. Farnaz Khan also from Center for Sight, Hyderabad, Dr. Harshita Nahata from Narayana Nethralaya, Bangalore, Dr. Mritika Sen from Shankara Nethralaya, Chennai, Dr. Shravanti Nagaraj from Narayana Nethralaya, Bangalore, Dr. Salin Nepal from Shankara Nethralaya, Chennai. And our entire session includes a myriad of topics, and we have tried to include all possible differentials of leucocoria, including retinopathy of prematurity, toxocariasis, retinocytoma, retinoblastoma, atypical retinoblastoma, Coats disease, persistent fetal vasculature, and we will be happy that we have our special lecturer by Dr. Santosh Unavasa to give us a logical approach to leucocoria. So may I request Dr. Lingam Gopal sir to please give brief opening remarks for the session. Over to you, sir.
Well, I think you already opened the meeting with very good remarks. I don't want to waste time in giving more remarks about the subject, which we are eagerly looking forward to the presentations by all the speakers, especially Dr. Santosh, who is going to give us a logical approach to leukocoria. And just to emphasize the point that leukocoria can always be very easy to diagnose, but can also be sometimes extremely difficult to diagnose, even for so-called experts, when you end up in actually doing a biopsy for a lesion, which you should not be doing a biopsy, and the other way around, enucleating an eye which should not be enucleated. So it's useful to know the whole gamut of presentations of leukocoria so that we can at least plan that 99% of the time we won't make a mistake. I don't think I will waste any more time with these opening remarks. I would like to ask Dr. Rolika to start with the presentations.
Thank you
Thank you.
so much, sir. And thank you for the blessings and opening remarks, sir. And we will start our session with the logical approach to leucocoria from Dr. Santosh Ji Honavar. And we thank him for for coming up with this entire session on leucocoria. And thanks for giving me the opportunity to organize it for you. Over to you, sir.
One second. The slides visible?
Yes, sir.
Okay. Right. I'm going to go give an approach to leukocoria, an overview, and address all the common causes of leukocoria in this talk in a very simplistic manner, useful for general ophthalmologists and not really specialists. The upcoming case presentation will, of course, be in much detail, and discussions will delve into the finer aspects of these individual entities. If you look at the list of leukocoria, it is quite daunting. There are more than 50. Leukocoria is the most common symptom and sign of retinoblastoma. It could be unilateral or bilateral. It is seen in about 50% of children. Except for group A retinoblastoma, B, of course, if it's in the macular area, even if it is small, C in the posterior pole, D and E definitely will present with leukocoria. Even an eccentric group T retinoblastoma, even if it's not in the posterior pole, will have a glimpse of leukocoria in some angle, whereas group E retinoblastoma, which fills more than 50% of the eye, will definitely have leukocoria. Now, along with leukocoria and retinoblastoma, you may find redness of the eye. This is absolutely necessary to recognize, because a child may come with what looks like inflammation or conjunctivitis, but the lurking leukocoria may be the cause for all this. A necrotic retinoblastoma can induce sterile inflammation and present exactly like this. Children with what looks like congenital glaucoma, ophthalmic eye, can also have leukocoria behind. If the cornea were to be more hazy than what it is in this picture, obviously a glaucoma specialist will miss it. And if they're not in a habit of imaging the eye, at least with ultrasound B scan or UBM, then they may end up doing trab and trap, as it has happened in several situations in the past. Even a thiazical eye patient who gave a history of minor injury resulting in inflamed eye and finally ending up with phthisis, you can see a definite whitish reddish reflex just behind there. So obviously it is retinoblastoma, which was necrotic, that has caused this thiazical or atrophic eye. Diagnosis of retinoblastoma is very simple. It's just the indirect ophthalmoscopy supported by ultrasonography. Ultrasonography picks up calcification, and MRI is required for the risk factors, radiological risk factors such as choroidal invasion, optic nerve invasion, extraocular extension, etc. But if you are in doubt about the etiology of leukocoria, when the media is opaque and you can't see the tumor itself, then it's a good idea to do a CT scan. Although CT scan gives a definite radiation to the eye and may theoretically predispose to second malignant neoplasm, it is essential to detect calcification, which is not seen in MRI. MRI is not a good tool to detect calcification. If you're not able to make out calcification on ultrasound B scan in an opaque media, suggest that we do a CT scan to look at intraocular calcification. Especially if it's a thiazical eye, if the calcification is within the eye in the vitreous cavity, that suggests it is because of retinoblastoma. Whereas if the calcification is in the coats of the eye, a concentric calcification like that may mean that it is dystrophic calcification in a thiazical or atrophic eye. MRI, as I mentioned, would tell you about optic nerve invasion and also choroidal invasion, which are considered radiological risk factors. Now, retinocytoma can also cause leukocoria. Obviously, retinocytoma is detected in older children, sometimes even on screening, but there is a glimpse of leukocoria if the retinocytoma is present in the posterior pole. This, of course, would cause leukocoria. At least in pictures, it will show up as a variation in the red reflex as compared to the other eye when you have a lesion of this sort right close to the posterior pole. This is on the nasal side, but in certain glimpses, it may also appear to have leukocoria. So retinocytoma as compared to retinoblastoma, retinocytoma, retinoma occur in older children who are asymptomatic, often seen on screening or by incidental detection. Typically extramacular, translucent, relatively avascular, generally does not have SRF. Retinal, choroidal or chorioretinal atrophy, RP alteration are very common with it. Now, if you look at 10 most common pseudoretinoblastomas in a specialty practice, in a Western situation, you find these. Many of these may not find a place in a list which is Asia-centric or India-centric. But just for the sake of completion, if I show you this, you find that non-retinoblastoma leukocoria, you find Coats disease on top, followed by persistent fetal vasculature. And for some reason, vitreous hemorrhage seems to be quite prevalent in Western countries, followed by ocular toxocariasis, FEVR, even rhegmatogenous retinal detachment finds a place, coloboma, astrocytic hamartoma, combined hamartoma, although it is not leukocoria, it's altered red reflex, and endogenous endophthalmitis. This is 10 most common pseudoretinoblastoma in a specialty practice in a Western situation. Now, based on age itself, you can subclassify leukocoria. The most common in children younger than 1 year, infants, is PFV in about 50%, followed by Coats disease and vitreous hemorrhage. In a child who's between 2 to 5 years of age, Coats disease comes on top, followed by toxocariasis and PFV, whereas in older children, again, Coats disease is on top, about 57%, followed by toxocariasis and FEVR. In India, we find that these are the 5 most common causes of leukocoria, although there is no hard data. Coats disease, PFV, toxocariasis, astrocytic hamartoma, and medulloepithelioma, and try to address many of this. Now, if you are familiar with the way retinoblastoma leukocoria looks, leuco is white and retinoblastoma leukocoria looks white. It may be pale white, may have a lighter tinge of yellow, maybe off-white, but it is on the borderline of white, whereas this is typically yellow, golden yellow. This is called xanthocoria. So when you have a child who seems to have a different white reflex or different looking reflex apart from retinoblastoma, if it looks golden yellow like this, and when you go close up, you might see all these dilated vessels and sometimes even telangiectasia, you're looking at a child with Coats disease. So this is typical xanthocoria seen in Coats disease, whereas this is typical leukocoria seen in retinoblastoma. So there's a qualitative difference in reflex in Coats disease. When you look at a child with Coats disease or with indirect ophthalmoscopy, you find this peripheral retinal telangiectasia, whereas in retinoblastoma, you still find dilated blood vessels, which are uniformly dilated and they dip into the tumor of this. They don't go on to continue to the mid-periphery or periphery, whereas in Coats disease, you find that these abnormal blood vessels extend right up to the mid-periphery and periphery. In Coats disease, there are macular changes, which may sometimes look like a tumor, but they are very refractile and bright yellow. This is nothing but a collection of exudates in the macular area. Although the disease is in the mid-periphery, periphery, macular area can have this exudation. Sometimes these exudations can have nodular elevations also, and they are hyper-reflective on ultrasound. You may find as if they are calcified, but that's not retinoblastoma. Retinoblastoma, a macular tumor would look like this, whereas this is definitely qualitatively different, and that will tell you that it is Coats disease. When you do ultrasound B scan in Coats disease, you find retinal detachment, and because of subretinal exudates, you may find thickening of the retina, whereas in retinoblastoma, despite the presence of retinal detachment on top, if it's an exophytic tumor, you'll still find a calcified intraocular mass. If you have any doubt at all, you can do RETCAM based FFA, and that sorts the issue in a majority of patients. That's Coats disease, very typical. You can see intra and subretinal exudation, abnormal blood vessels, peripheral retinal telangiectasia, total bullous retinal detachment, whereas this can be confusing. This is actually a case of Coats disease. You may find some evidence of peripheral retinal telangiectasia, but what could be confusing is this yellowish, what looks like a mass right behind the detached retina. It can be quite confusing, and sometimes these patients may end up getting chemotherapy or even end up getting enucleation done. So it's a good idea to image these patients, not stop at B scan. Also in patients where the media is opaque, where you cannot see the fundus, it's a good idea to image these patients. This child has hazy cornea, and on close-up picture, you find that he must have had some inflammation in the eye, resulting in sorts of iris atrophy and posterior synechia. But when you look at the retina, it is quite typically Coats disease. But if you're not able to see the fundus, you have supposed to image it. When you do B scan, it may not always sort out the issue. You may find hyperreflectivity, echogenicity in the vitreous cavity. On MRIs, it is somewhat differentiable, But this particular patient did not have typical MRI appearance of Coats disease. This is one more patient where there is hazy media, but we were able to capture pictures, and that is very typical Coats disease. And that's how the B scan looked like, very highly echogenic. And on CT scan, all you find is diffuse haze in the vitreous cavity. It is uniformly isodense, or there might be heterogeneous density. But what is CT scan done for is to look for chunky calcification, which may suggest retinoblastoma. But if it is uniformly white like this, it's most likely Coats disease. Again, a child with Coats disease where retina cannot be seen easily, diffuse echogenicity on B scan. This doesn't always sort it out unless there is chunky calcification that would suggest retinoblastoma. So you have to actually depend on MRI or a B scan, whole eye B scan like this. This is Martini glass appearance, where you find that is the detached bullous retina, and there is a central area where these two bullae of detached retina meet, and that looks exactly like this. On MRI scan, you find that on T1, there is hyperintensity. So this is hyperintense on T1, and it is hypointense on T2. That's very characteristic of Coats disease. You can see different sequences of MRI, hyperintense on T1, hypointense on T2, and in flare sequence, you find that it does not attenuate. Subretinal fluid in Coats disease does not attenuate on flare sequence, whereas the vitreous cavity attenuates. So that's very typical of Coats disease. So if you have any doubt at all, you can ask your radiologist to do fluid attenuated inversion recovery sequences. That will more reliably tell you that you are looking at Coats disease. If you have facilities of good MRI, then you can ask for what is called a space sequence. Space is spin echo sequence, where you can actually even look at intraretinal cysts or macro cysts and a peripheral clump of exudation, or even VPRT that easily stands out when you do the space sequence. The next disease of consequence is PFV. It is present at birth, and one characteristic feature is that these patients have relative microphthalmos. Eye is slightly smaller than the other eye. If the corneal diameter in the normal eye is 11 millimeter, even 10.5 millimeter in the affected eye is significant. Relative microphthalmos may not conform to the definition of microphthalmos. These patients tend to have prominent ciliary processes and an evident posterior polar cataract. That's exactly how a patient with persistent fetal vasculature looks like. Relative microphthalmos, an anterior leucocoria. You can see even in this picture that the leucocoria is quite anterior. It is not the posterior deep leucocoria that you're looking at. And of course, when you look at the fundus, the diagnosis gets easily sorted out. That's the eccentric cataract that these patients tend to have, sometimes in the center, sometimes eccentric. But nevertheless, the fundus appearance is quite characteristic in persistent fetal vasculature. It can be bilateral. This is a situation where it is bilateral. On ultrasonography, you find that there is this fibrovascular stalk that emanates from the disc and gets attached to the posterior lens spool, whereas in retinoblastoma, you don't find that. Again, in PFV, you find this Martini glass appearance, where there is this central space and there is a small stalk which obviously goes to the optic disc, and that's the histopathology simulation of the same. But it may not always be Martini glass. Sometimes it could be a wine glass appearance, depending on the height of the bullous retinal detachment. The shape varies. This actually is like a wine glass, and that is the simulated appearance. So these are typical of FPV. Now it could be bilateral. We always think that it is unilateral disease. No, it is not. 10% of these patients may be bilateral, and when there is bilaterality, there is confusion. Bilaterality is associated with Norris disease, Patau syndrome, or Walker-Warburg syndrome. And if it is bilateral and the fundus is not visible at all because of dense uh, vitreoretinal changes, then there is diagnostic dilemma, and then we have to differentiate it from FEVR. Now, there are typical differences between FEVR and PFV. The cause, of course, is different. FEVR typically affects bilateral, although asymmetrically, whereas PFV typically is unilateral. 10% of them I said are bilateral. In FEVR, the retinal fold runs from the optic disc to the peripheral retina, whereas in PFV, fibrovascular stalk runs from the optic disc to the posterior aspect of the lens. Eye size, there is generally no difference, symmetric, normal-sized eye in FEVR, whereas in persistent fetal vasculature, there is relective microphthalmia. FEVR is a progressive condition, whereas PFV tends to be non-progressive after the initial progression. Systemic associations are implicated in both and bilateral FEVR. Advanced ROP can also simulate any of these conditions in the child with advanced ROP, where sometimes it's maybe difficult to differentiate unless there is a strong history. Coming to toxocariasis, if it is anterior, can have anterior segment inflammation resulting in synechia, etc., whereas in retinoblastoma, synechia is rare. In a peripheral toxocariasis, you find a calcified peripheral mass and there is a falciform fold. So desmoplasia is characteristic of toxocariasis, whereas in retinoblastoma, there is no desmoplasia or dragging. This is called drag disc appearance of a posterior toxocara granuloma. Toxocara can have intralesional calcification, and that is why it is a simulating condition for retinoblastoma. Retinal astrocytic hematoma, there are various types. Non-calcified variant is like a button sitting on the retina, obscuring the retinal vessels, whereas the calcified variant has this fish egg kind of confluent, discrete confluent calcification. That is exactly how calcified astrocytoma looks. That's how brightly it shines if it is typical calcification in a retinal astrocytoma. But sometimes it could be dense calcification. This is a variant here where there is dense calcification looking like retinocytoma or a regressed retinoblastoma. In astrocytoma, the retinal vessels actually circumvent the lesion. They go around the lesion or the lesion obscures the blood vessel. Whereas in retinoblastoma, these blood vessels would have fed into the lesion or disappeared into the lesion to emerge somewhere there. So that's a very typical vascular chain that is associated with astrocytoma. And if you have any doubt at all, OCT sorts it out. Because whenever child has astrocytoma, you have to look for the signs of tuberous sclerosis. These are some of the major and minor criteria for tuberous sclerosis. The last lesion, important lesion that's a simulator, is medulloepithelioma. Medulloepithelioma can look like retinoblastoma if it is large, especially if it is malignant teratoid variant. It would have calcification as well. Non-teratoid medulloepithelioma may not have calcification, whereas teratoid medulloepithelioma is typical to have calcification. It's a peripheral lesion, ciliary body lesion. So there will be what is called zonular coloboma, also called lens coloboma, but it's the zonules that are missing in the area where the tumor is located, thus distorting the lens. It looks like lens coloboma, whereas in retinoblastoma, that really doesn't happen. Sometimes leucocoria may be the appearance. This patient was actually retrieved from the surgical table of a pediatric ophthalmologist who was just about to make an incision. He fixed the eye there. This is a videograph. And when he fixed the eye, he found that the zonules are missing just before he made the incision. And there is this concentric shadow just behind the lens. So what happens in medulloepithelioma is that that's the tumor in the ciliary body. The posterior capsule of the lens acts like a scaffold for the tumor cells to grow, thus producing a retrolental membrane, which is often vascularized. So the presence of a vascularized retrolental membrane is a pointer towards the presence of medulloepithelioma. Medulloepithelioma has hyaline cartilage and can have calcification. As I said, these are some of the variants of medulloepithelioma. Endophthalmitis, endogenous endophthalmitis can simulate retinoblastoma, but the presence of overwhelming inflammation is a pointer towards endogenous endophthalmitis, although sometimes you can't rule out a necrotic retinoblastoma in the setting of tumor necrosis. Fungal endophthalmitis sometimes can look like clump of vitreous seeds, and that could also be a mimicker. But any child who has endophthalmitis like picture, sterile inflammation, preseptal inflammation, orbital cellulitis, you should look for leucocoria because this could actually be a case of necrotic retinoblastoma with sterile or inflammation. Coloboma, of course, it's just to be mentioned, but it is not a serious differential diagnosis because there are telltale signs of coloboma that are evident. Fundal coloboma may be associated with iris coloboma, and that sorts it out. So in the presence of simulating condition, a careful evaluation and appropriate investigations help differentiate retinoblastoma from these. That's of course a flow chart, but I don't have time to cover that. Diagnosis would be by a good examination and anesthesia, ultrasound B scan, UPM under anesthesia, a CT scan where you're looking for calcification, MRI when you're looking for very subtle signs, as I showed both in PHPV and Coats disease. There are very specific signs of MRI, genetics where you really require, and of course, liquid biopsy currently can help differentiate retinoblastoma from other simulating conditions. So in conclusion, I would say that leukocoria is a red flag in children, needs referral to an ocular oncologist or an appropriate retina subspecialist. A good EUA is the key to diagnosis, and ancillary tests can be used to support the diagnosis. Must rule out RB and avoid inadvertent intraocular surgery, and that is the goal. Thank you so much.
Thank you so much, sir. Thank you for all your pointers. And I think that's a very good overview and a briefing about what all we are going to discuss in the webinar. So I do have a question for you. What would be your tips and suggestions for anybody who is about to go for, like, how to prevent inadvertent intraocular surgery in cases with these, with
Yeah,
leukocoria?
if you follow a sequential method of evaluation and rule out retinoblastoma, then you can avoid intraocular surgery in a majority of situations. That's what I would say. So you have to go systematically and not jump to surgery if there is any indication that it could be retinoblastoma.
Right, sir. And another question would be that for the general ophthalmologists, what would be your 3 tips to timely refer when they have cases like of leukocoria, and how should they pattern it?
General ophthalmologists, I don't think, are equipped to deal with any of the differential diagnoses of leukocoria except, of course, cataract. So they have to refer any patient who has leukocoria, which is not because of cataract. Coats disease, PFV are definitely for the retina specialist, pediatric retina specialist to handle. Retinoblastoma is for retinal specialists trained in ocular oncology or ocular oncologists to handle it. So any child with leukocoria where it is not cataract should be referred. And even if a child has cataract, they have to do posterior segment imaging before venturing on to do cataract surgery, because cataract can be a secondary cataract in an eye with retinoblastoma or any retinal pathology for that matter. So without doing an posterior segment imaging, no pediatric cataract should be done. No lensectomy should be done at all. And no primary posterior capsulotomy should be done if you're looking at some abnormal kind of a or a atypical cataract for that matter.
Right, sir. Thank you so much, sir, for your extensive approach and guidance for leukocoria. I would now begin the next session. That is going to be the rapid fire session of interesting cases. And I thank all the presenters and discussants for agreeing to be a part of the webinar. And the first case would be by Dr. Shravanti Nagaraj. And over to you, Dr. Shravanti, for retinopathy of prematurity. And we have Dr. Sushma Jaina, ma'am, as the discussant as well. Over to you.
So good evening, everyone. I'm Dr. Shravanti Nagaraj from Narayan Netralaya, Bangalore. I will be now sharing my screen. Am I audible?
Yeah, you're audible. I think the screen is stuck on the video slide. Maybe you can click on the back buttons when you were cross-checking. On the back buttons when you were cross-checking. On the back buttons when you were cross-checking.
Are my slides visible now?
Yes, yes.
Okay. So good evening, everyone. I would like to thank AIOS for this wonderful opportunity and under my moderator, Dr. Sushma Jaina, ma'am, today. So I will be taking you through a case scenarios on leukocoria in retinopathy of prematurity. So these are my acknowledgements. So coming to the patient number 1. So this is a case of a 50-week postmenstrual age preterm infant who presented with bilateral leukocoria with no prior history of ROP screening. So on the left-hand side, we can see the anterior segment of the left eye where the cornea is clear and there was 360-degree anterior and posterior synechia. Anterior chamber is flat and no NVI was noted. The lens was clear with retrolental fibrous retinal fold. On the right-hand side, we can see the B-scan showing moderate to high reflectivity vitreous echoes of funnel-shaped configuration, which suggested of stage 5 ROP. So we went ahead with the plan of pars plana lensectomy with pars plana vitrectomy. So as you can see, AC maintainer was placed, and with vitrectomy cutter, we are aspirating the lens matter. So once the lens aspiration was done, the 360-degree iris synechia was released. Now we note a sheet of retrolental membrane, and this sheet was dissected very carefully using the micro scissors. And it was dissected carefully from underlying retina from the periphery to the center. And it was freed from all the quadrants. So finally, there was a opening up of the peripheral trough using the vitrectomy cutter and the scissors. As we can see, 360-degree, it was released and it was cleared. So finally, the corneal incisions were hydrated well and subconjunctival DEXA was injected and the case was closed. Now coming to the second case, this was a 38-week postmenstrual age baby of ROP screening with prior history of treatment for sepsis, presenting with unilateral leucocoria. Now you can see the AC was shallow, no NVI, and there was 360-degree posterior synechia, total lens opacity, and the right-hand side you can see the right eye had zone 2 immature retina. The B scan shows extensive X-rays. Sorry. The B scan shows vitreous echoes with retinochoroidal thickening, which is suggestive of vitritis. So we went ahead with the surgery where AC maintainer was placed, and then vitrectomy was carried out. You can see there was extensive exudates in the cavity. On clearing up this vitreous exudates, we could see the underlying retina was very pale, sick-looking, washed out retina. So once we cleared out the entire exudates, silicone oil tamponade was used, and then the case was closed. By intravitreal antibodies like vancomycin dexa of half dose was injected, and the case was closed. So now you can see the B scans of preoperative and the postoperative B scan where you can see the resolving exudates. Now coming to the discussion points, what were the main points? Like both patients were preterm, presented with leucocoria and had 360-degree synechia. Now what was the difference between patient 1 and patient 2 was the laterality. In the patient 1, it was bilateral. History, there was no history of any sepsis. The lens was clear, and on ultrasound, there was a membranous fold with high spike echoes. Now, in the patient 2, it was unilateral. There was history of treatment of sepsis. There was lens abscess, and there was diffuse dot low to medium spike echoes. So the take-home points from this is not all leucocoria and preterm is stage 5 ROP. And also we should make sure that we take strong history, and also we should clinically correlate, which plays a vital role in the diagnosis. And I would like to ask my moderator, Dr. Sushma ma'am, for any discussion points.
Thank you, Shravanti. Can you hear me?
Yes,
Yes,
ma'am,
ma'am.
you're
Over
audible.
to you.
I'm sorry for the voice, though. So, like Shravanti said, if we are in a ROP clinic, if a preterm comes, it's always in the back of the mind. Sometimes we become so robotic that any preterm with a leukocoria, we by default think it's a stage 5, but diseases are not mutually exclusive to each other. So, ROP patient can have retinoblastoma coexisting. A ROP patient can have an endogenous endophthalmitis coexisting. So in this case, it was unilateral. Endogenous can also be a bilateral. So I think it is so important to keep our minds open when we are in the clinic, especially in pediatric. And we should always, even though you're a super specialized person, we should never forget that we are ophthalmologists first, or maybe physicians first, then ophthalmologists, and then retina, and then pediatric retina. So yeah, any other inputs from other panels would be welcome. I'm extremely sorry for the voice. So yeah.
Thank you, ma'am, and thank you, Dr. Shravanti, for the case. Thank you so much, Sushma ma'am, for joining us still. And I would just have a question from the audience, and that is, in cases of leucocoria, when you know that you have no clarity about what exactly is the diagnosis, and you're doing a vitrectomy, what are the pointers that you keep in mind because it could be any diagnosis ranging from benign to malignant, even though you have clarified it on B scan or imaging. But still, what are the pointers that you keep in mind, Sushma ma'am?
So first thing is, if I feel that there is something which is not convincing me of a clear-cut diagnosis, I wouldn't hurry in any procedure. So I wouldn't push myself to so go into surgical intervention. So
Right.
take as many opinions you want, even though if you take a single opinion and it is not convincing to you,
Mhm.
because you are the surgeon at the end of the day.
Right.
You are the one who are entering, and it's your responsibility.
Right.
So no matter the highest level oculoplasty surgeon is telling that this is not retinoblastoma, but if you feel that there is something off with this, do not intervene until your conscience and your doubts are cleared. So I think that's something which I'll always keep in mind if diagnosis is not clear cut. Yeah.
Right, ma'am. Thank you so much for that pointer. And Dr. Honavar, this one question is for you because I know that you have a paper written on it on vitrectomy and retinoblastoma. So, what would be your inputs on on a case where we are doing vitrectomy and we have a possibility of retinoblastoma?
The protocol is that if you have a confounding clinical diagnosis and maybe you have started doing the surgery, then you find that it is atypical for the diagnosis that you are considered and it could be retinoblastoma, then it is a good idea to send a vitreous sample for cytology, fresh sample, and confirm the diagnosis. If you wait on table for about 5 to 7 minutes, and if you have in-house pathologists, they would be able to tell you that they are seeing round cells. If you try to kind of process them, these round cells have a tendency to get degenerated, and then it may take a while for them to prepare a cell block, etc. So if you have any doubt at all, send a sample right away. And or if towards the end of the surgery you have realized that it could be atypical, then send the entire cassette fluid for cytology. They would do cytospin, get a pellet, and then do cytology as well. So that is the recommendation. And of course, currently anyway, everybody does no peritomy. Earlier, full-blown vitrectomy would involve peritomy. If it's a small gauge vitrectomy, then the damage is limited. There is no much orbital seeding. No, then it could be treated as accidental limited orbital disease and it is still salvageable. So and whenever there's a atypical clinical situations, getting a cytology input is very important.
Thank you, sir.
And
And
cryo the port and mark the area of the port. Suppose it comes to enucleation, we have to do en bloc excision. That means the entire conjunctiva around the port has to be excised. So always it may heal. You never know where you have made your port. So it's a good idea to mark the port and also cryo the port.
right, sir. Thank you so much, sir. And Dr. Lingam Gopal, sir, can I please request you to give us some inputs from your side in such cases based on your several years of experience in the field?
You mean you're asking about vitrectomy accidentally being
Rectum.
done?
Yes, sir.
I think most of the points have been well covered by Santosh. The only thing I would like to say is that the incidence of such an accident should be actually very low these days with support from so many investigations. And I'm sure in case of real doubt, you would like to maybe even do a liquid biopsy rather than go inside and do a vitrectomy unnecessarily when you know the damage caused is much more than if you just do an entry chamber tap. So basically, you try to take inputs from the investigations, and it's not enough that if you see if you are an experienced person, but in case of a doubt, should have a second opinion, even if you are the senior most person in the institution. There's no harm in having an opinion from a junior person because definitely two brains are better than one in difficult situations like a diffuse infiltrative retinoblastoma, where you may not have a calcification, you may only see a retinal detachment on ultrasonography, and child is also not exactly in the age group of usual retinoblastoma. If an OI is normal, then you can mistake that retinal detachment with PVR or something like that and try to operate on such eyes. So there, when you have it in doubt, please take one more opinion, then only go in a very careful manner. Thank you.
Right, so and so how often in your experience do you see the advanced stage ROP presenting this way as shown by Dr. Shravanti?
Advanced stage retinoblastoma presenting as ROP, stage 5. Is it a technical?
I mean advanced stage ROP presenting with leucocoria. How often do you see that?
Advanced stage ROP, okay, yeah,
Yes,
that's
sir.
pretty common. In fact, unfortunately, we do deal with stage 5 ROPs quite routinely. So almost every day of my OPD, I see 1 or 2 stage 5 ROPs. So it's still unfortunate, but it does happen in India very commonly. Yeah.
Thank you so much, sir. Thank you. Now, from the standpoint of retina, we move on to uveitis component, and now I welcome Dr. Salin Nepal to share his screen for the case 2 on toxicariasis, and the discussant for the session will be Dr. Pathapratim Datta Majumdar, sir. Over to the team.
Hello, sirs and ma'am.
Perfect.
Good evening. I'm Dr. Salil Nepal, and I'll be presenting a case on toxicariasis. Dr. Pathapratim Datta Majumdar sir will be my mentor moderator. A 4-year-old boy presented to our OPD, accompanied by parents who noticed white reflex in right eye since 1 month. Then parents consulted a nearby ophthalmologist to know about the condition, and there they came to know about the decrease in vision in the right eye. The best corrected visual acuity in the right eye was counting fingers close to face, and visual acuity of the left eye was 6.6. The child's perinatal history was The child's perinatal history was unremarkable. There were no complications at birth, and the mother denied any adverse obstetric events, systemic illnesses, or significant exposures during pregnancy. There was a history of contact with pet dog. The contact of the pet dog was, however, not dewormed ever. On examination, the right eye anterior chamber was quiet, lens was clear, there were occasional cells in the anterior vitreous, and mild vitritis was present. The slit clamp examination and fundus of the left eye was unremarkable. In the fundus examination, it revealed a large, well-defined, elevated whitish lesion located in the posterior pole, slightly temporal to the optic disc. The central area shows a very bright light, bright white fibrotic focus, which was surrounded by a pale and depigmented retina forming an irregular ring. There were prominent straightened and dragged retinal vessels that appeared to be pulled towards the lesion, indicating there was a retinal traction. The UCB scan also showed that there was a retinochoroidal elevation at the macula. There was no hyperreflective echoes with black shadowing. With this information, these were the DDs. But first, we thought it was ocular toxicariasis because it was an elevated whitish granuloma. There was prominent vitreoretinal traction, and vessel straightening and dragging was present. The retinoblastoma could also have been presented as a melanotic mass with calcification, but and the retinal vessels dragging towards the lesion or fibrotic traction was not in the retinoblastomal presentation, would not have been there. Granulomatous fibrotic appearance rather than a solid tumor mass would have been there if it was retinoblastoma. And in USGB scan, there was no sign of calcification. It was more like a central fibrosis than calcification. Coming to the Coats disease as another differential, there was no exudative retinal detachment, there was no marked telangiectasia and aneurysmal vessels, and there was no subretinal lipid. And Coats disease doesn't usually form granuloma. Another close differential was ocular toxoplasmosis. However, in this case, we did not find any chorioretinal scar with pigmentary changes with or without adjacent satellite lesions, which usually occurs in ocular toxoplasmosis. And these lesions are typically more flat than the raised granuloma seen here. After the clinical examination, the investigations were done in which we found the Toxocara IgG serum antibody was raised. Anti-toxoplasma IgG and IgM were normal, and routine blood investigation showed mild eosinophilia. The management for this kid was counseling to the parents that since he is only white one-eye patient now, the guarded visual prognosis was explained as to how they should be really careful with the other eye and make and try to protect the other eye with maximum at the optimal. And the other one thing was routine observation.
Yeah, so Rolika, I'll just try to highlight few things related to the ocular toxocariasis and also the uveitic condition which can actually mimic present with leucocoria. So most of the time the leucocoria in uveitis in children is related to the complicated cataract. So it can happen, one of the most common cause other than ocular toxocariasis is JIA. And also, you need to understand that leucocoria in uveitis can be due to the severe vitreitis, which can be seen in intermediate uveitis. If there is a severe vitreous inflammation, it can happen in cases in children with chronic endophthalmitis. But there's some salient feature of the ocular toxocariasis here is that the AC is typically quiet in such scenario, and the crux or the clue to the diagnosis is usually the vitreitis, traction band, and granuloma. The combination of it is there in a child with vitreous inflammation. Then one must think about the ocular toxocariasis. Now, the causes of toxocariasis in ocular toxocariasis can be the granuloma related mass effect, as we have seen in these cases. Mostly these granulomas are the posterior pole granuloma. The peripheral granuloma rarely causes that. And the vitreous opacity and membrane sometimes can cause this kind of appearance. Also, the complications, for example, if there is a retinal detachment, tractional or combined RD, if you see in a cases of toxocariasis, then it can happen. And of course, as I mentioned that a secondary cataract or other complication can cause. So one must remember that all this in ocular toxocariasis are actually the late sequelae, the presentation in late stages. So three forms of ocular toxocariasis, because we are dealing with this topic, one should remember. One is the posterior pole granuloma, which is more common and can present with leucocoria. The other varieties which can actually be there is the peripheral granuloma and the chronic nematode endophthalmitis. The posterior pole granuloma and this endophthalmitis like picture in toxocariasis can have this kind of leucocoria like picture. I'll just sum up with the 4 points here. One thing you have to remember that the serological test for ELISA test for the anti-Toxocara IgG is the very good test, but this test is not actually available everywhere in our country. The reason is that for doing this test, we need a live third stage larva. So many laboratory actually they don't make this test available for the clinician. So you need to actually search whether any such laboratory facility is available near your center. And most of the time, the diagnosis of toxocariasis is clinical, as I mentioned here. And routine the blood MRI or CT scan is not required for isolated toxocariasis because neurotoxocariasis is rather rare. So perform neuroimaging if there is neurological symptoms such as like headache and seizure. And another important point to note is that stool examination in toxocariasis in human usually not helpful. If you have a history of contact with a pet which has not been dewormed ever, like in this case, so sometimes you can actually ask the veterinary for the stool examination of the dog, which can show the presence of the larva. But in human, this test is not very helpful. Next slide. So the treatment is mainly the corticosteroid and the combination of albendazole is cited, but albendazole actually is not recommended or mandatory. If there is any high suspicion of any active larva migrans, then only you can use it, because sometimes what happens if you give albendazole without any oral steroid, there can be severe inflammation which can cause another kind of inflammatory reaction inside the eye because of the dye of inflammation. And pars plana vitrectomy can be done if there is a persistent vitreous opacity which is not cleared by any anti-inflammatory treatment, or if there is any development of tractional detachment or any other complications related to that. That's it from our side.
Thank you so much, Dr. Saran and Dr. Pathapratan, sir. May I request Dr. Mahesh Shanmugam, sir, for answering this question from the audience. So what do you think, what would be your indications of vitreous biopsy in cases like this presenting with vitritis component? So just requesting you to unmute, sir.
A very nice presentation and illustrative case. The one where we can have a confusion is the chronic nematode endophthalmitis appearance. So eyes presenting with a diffuse infiltrative retinoblastoma or say, eyes filled with vitreous seeding can appear, either of them. The Toxocara endophthalmitis can mimic that kind of vitreous seeding as well, because in both situations the eye is quiet and white as well. And in a diffuse infiltrating retinoblastoma, you may not be able to see a calcific mass. So that's where the confusion comes. So I would not jump in to do a biopsy in that situation. So try to do imaging. Imaging for toxocariasis as such may not be required, but to rule out retinoblastoma in select situations, we may have to do an imaging like ultrasound as well as MRI to see if there is a diffuse thickening of the retina and to rule out retinoblastoma. And if in case it's still doubtful, I would probably treat it with a course of steroids to see if the inflammation subsides. If it's inflammation, it will subside, but if it's vitreous seeding, it's unlikely to subside. Only subsequent to that, if in case the diagnosis is still uncertain and if there is visual potential, then we may have to consider doing a biopsy, but then taking all precautions to, if at all, like if a liquid biopsy is available, then that would be a much less invasive procedure by taking an aqueous step and doing it. If it is not possible, is when taking all precautions, we can do a vitreous biopsy to rule out if it's retinoblastoma.
Right, sir. Thank you so much for indicating that. First of all, we have to make sure that we have ruled out the possibility of retinoblastoma. Any inadvertent entry into the eyeball is absolutely a contraindication. Thank you so much, sir. May I also request Dr. Mangal Dogra, sir, to give his opinion. The question is that how often do you see patients presenting in the pediatric age group with tuberculosis and leucocoria?
Think it's only if you have a large sort of a abscess or a tubercular granuloma, which mostly, of course, in a small child may be rare, but it's not that it's not seen at all, that it may mimic such a picture, because it has to be a subretinal large abscess or a large granuloma, which might mimic. But mostly in these situations, you don't see what has been very nicely highlighted earlier by Dr. Santosh and later by Partho, that you have so much of, you see proliferation happening around this kind of toxocara lesion, because that is very typical. That's how we differentiate it. I think there you won't have, it will have a acute onset in those cases.
Thank you, sir. So another question that I have it open for discussion would be, as Partho sir has rightly indicated in his tips, that it has to be a combination of systemic steroids, topical steroids, cycloplegics, along with oral albendazole. Is it the same protocol that everybody follows, or is a slight variation that you would like to discuss?
I think the protocol is very well known to everyone. The protocol is very well defined, because that's only going to be used if it is not if it's already old, scarred, sort of a granuloma with a fibrosis there. Most of the time, we may not do anything. We just watch it and let it be there. And that is a situation in most toxocara lesions, which we find, at least, because that is active case will be very, very, very rare.
Actually, just subtenon steroids also work quite well. So not all the time I treat the patients with oral steroids. So a subtenon steroid also decreases inflammation, and you may be able to see the lesion much better. Albendazole, as Dr. Partho mentioned, we don't usually treat the patient with albendazole.
Right, sir. Thank you, sir. And Dr. Partho, sir, thank you so much for the lovely discussion. And we will be waiting for the titles to come to India. Thank you, sir. Over to you, Dr. Rishita.
Thank you, ma'am. Now I request Dr. Anureet to share her screen for the case on retinocytoma, and the discussant for this case will be Dr. Seema Das. Over to you, Dr. Kaur.
Good evening, one and all. I thank AIOS and my mentor for giving me this opportunity. I'll be sharing my screen.
Yep, perfect.
So, brief introduction about retinocytoma. It is also known as retinoma, which is a rare and benign intraocular tumor that primarily affects the retina. It is often considered a precursor or a differentiated form of retinoblastoma, and the age of presentation in these cases ranging between late teens and early 20s. So we often find ourselves in a state of dilemma when we see a case with this whitish lesion, which is RB-like looking lesion, which could either progress or be stabilized over the time. So to straighten out all this, I'll be describing few scenarios. So scenario number one, a child, Master X, he came to us and he was diagnosed with bilateral intraocular RB. He underwent left eye secondary enucleation and intravenous chemotherapy 6 cycles. His genetics mutation was positive. He had a younger sibling whom we detected intraocular RB bilateral on day 19th of life, and we started him on intravenous chemotherapy for 6 cycles. For him also genetic mutation was positive. Now, as we can see on the fundus photograph of the first child, this is an active retinoblastoma. We see a smooth lesion, dome-shaped lesion on the OCT and a thickening of the overlying retina above it, which shows that it is active tumor. Now, on treatment, there was regression of this lesion as confirmed on the OCT. This is Master Y. This was the younger sibling. The first two pictures show the on presentation fundus photographs, and after treatment, the lower pictures showed regression of the tumor. So we went ahead with parental screening, and this was the father of both the children. And we saw whitish lesions which were present. One was superior nasal to the disc, and one was present in the inferior nasal quadrant. So we did OCT and it showed a smooth lesion with ILM being preserved and there was no SRF. So we made a provisional diagnosis of retinocytoma in father and further both the kids having retinoblastoma. Now coming to scenario number 2, where a 16-year-old female came to us with unilateral diminution of vision. By looking at the picture, we made a differential diagnosis of either adult onset retinoblastoma or a reactivated retinocytoma. Now, we gave her treatment, we gave her intravenous chemotherapy and we did plaque radiotherapy, but pre and post treatment pictures look similar. So there was no much response to the treatment that was noticed. But one fine day, she came with a worse picture where there was tumor reactivation and she had to undergo enucleation. So on histopath, there was no atypical cell noted in this case, and there were chronic inflammatory cells which were noted. 10 years later, she had a baby girl who was diagnosed with bilateral RB, and she was under treatment with us. So on hindsight, mother had a probable retinocytoma, which did not show good response to the treatment, and histopathology was also not suggestive of retinoblastoma. However, when the child came to us, it was bilateral RB, and she was mutation positive. So last but not the least, one more child came. So this child underwent intravenous chemotherapy, IAC, and focal treatment. The left side picture is of May 2025, and after 6 months, the tumor seems to be almost similar. On doing OCT, the height of the tumor was also similar, and it did not show any signs of progression or deterioration. So we thought that it could be basically a retinocytoma or regressed tumor. So the importance of multimodal imaging in these cases, in case of fundus autofluorescence and STOCT, these are useful in evaluating calcification and atrophy. In case of multicolor imaging, it is useful for analyzing depth and extent. OCTA is useful for assessing the microvascular changes. The overall goal of this imaging is to evaluate the microstructural and microvascular changes associated with the tumor. So concluding it, it is very important to form a pedigree chart, to do parental screening in cases of retinoblastoma, and to understand the genetics as a crucial part of overall management. So comprehensive documentation at each visit is very crucial for a regular follow-up to identify any signs of malignant transformation of retinocytoma into retinoblastoma at an earlier stage so that we can treat it on time. Thank you.
Thank you, Dr. Anurit. May I request Dr. Seema ma'am to please give her inputs on the case?
Thank you, Ralika, and thank you, Anurit, for highlighting these two cases. So I think retinocytoma is something which possibly we maybe either underdiagnose it or sometimes we probably overdiagnose it, either as retinoblastoma. So I think as Anurit highlighted, the two settings where we possibly see retinocytoma are when we have an familial RB and when we screen either the siblings or the parents. That's when we kind of, end up seeing those retinal lesions, which looks like RB, but which does not progress, which has been stable over the years. And those possibly are either spontaneously regressed retinoblastoma, which was the previous term which was used for retinocytoma, or retinocytoma as we call them now. I think the telltale signs are the presence of calcification, which are signs of spontaneous regression, some amount of scarring within the lesion, but no increase in size as we follow up these patients. So other than that, I think they might look pretty similar. There is no way to differentiate them if there is no signs of progression or increase in the size of the lesion, or we don't have an histopath. The other setting where we tend to get this retinocytoma-like areas are when we give treatment to the tumor and some part regresses, gets calcified or gets into a flat scar, but there is still some area which remains as it is. It's like a fish flesh sort of appearance. So those possibly are the benign counterpart of the retinoblastomas, which do not respond very well to treatment. But I think the question which we face, the dilemma that we face is when we see a lesion which looks like a retinocytoma, is whether we treat it or we follow it up. So that's usually the scenario that we face in the clinics. And
Documented growth is definitely a situation where we have to treat those lesions, and possibly if we have an imaging modality like OCT, some of the kind of early indicators like breach in the internal limiting membrane, very early seeding, some amount of very minimum amount of SRF if that is there. This sometimes can help us in clinching the diagnosis more towards a retinoblastoma rather than a retinocytoma. And of course, if we do a serial follow-up, do a serial OCT, even a subtle increase in the size, thickness, appearance of bumpiness within a relatively flat-looking lesion are possibly again telltale signs to tell us that some activity is going on within the lesion. So yes, transformation to retinoblastoma is possible in a retinocytoma. So follow-up is important. And I think the most important part here to understand is that whether it's a retinocytoma or retinoblastoma, the implication for genetic counseling is same. So that's why it's very important to screen the siblings or the family or the parents to find those lesions, identify those lesions. And if we detect those, the genetic counseling goes on the same path as we do for the retinoblastoma. So I think that's what it is there. The second patient, in fact, when we are just preparing this presentation, we went back to the second case because that's one case where we still don't know what exactly happened. She did not respond to treatment. This patient was, I think we saw about 10, 11 years back. She didn't respond to treatment, looked like a very, adult onset RB. And ultimately, one fine day, she comes back with a lot of increase in the thickness of the lesion, like the picture shows as if there is a reactivation of the tumor. But on enucleation, there was nothing, there was no malignancy. It was just more of chronic inflammatory cells. There were no fluorates also to say that it was a retinocytoma. So we were still at a dilemma because the genetic testing, she refused for any kind of genetic testing. At that time, cost was an issue. But 10 years down the line, when she came back, she was lost to follow-up. She came back 10 years down the line with the child having a bilateral retinoblastoma. So I think on hindsight, we know that possibly it was a retinocytoma. Whether there was any activity going on at that time, difficult to say. So maybe some opinion from the expert panel here. How do you approach those kind of cases, and what exactly are those scenarios? Does a retinocytoma can also undergo activation and behave like those without any transformation to retinoblastoma is something which we would look forward to listen to.
Right, ma'am. And just a question, ma'am, that in the case where enucleation was performed, was bread loafing for the sample done?
Everything was done. This slide, this eyeball was reviewed by two different pathologists from two very reputed pathologists, but there are no signs of retinoblastoma.
Seema, this can happen after plaque brachytherapy. Even remotely, there is some kind of inflammation, tumor necrosis induced by plaque. I've seen it even in retinoblastoma where there's suddenly a flare-up size, increase in size of the tumor, intralesional hemorrhage, sometimes even vitreous hemorrhage, which settles down with steroids. If it doesn't, we have enucleated and we have found that there is no viable cell left in the tumor, only macrophages and inflammatory cells. So this is something that is possible with plaque brachytherapy, even in
that was the that was the possibility which was finally considered, that possibly in post brachytherapy retinopathy changes which probably mimicked as if the tumor has actually grown in size. But to begin with, whether it was a retinocytoma or a retinoblastoma is something still don't know.
If it doesn't change at all in configuration after optimal chemotherapy, then it is either a very well differentiated retinoblastoma, almost like retinocytoma, or a retinocytoma itself. So if there is no change at all with optimal chemotherapy, I would simply observe. And if there is any further change, then only I would do the next intervention. But yeah, plaque brachytherapy, especially following chemotherapy, can give rise to these kind of changes.
Yeah.
Right, sir. Thank you, sir, and thank you,
I
ma'am.
can make one comment.
Yes, sir. Over to you, sir.
About the subsequent case where it was diagnosed as retinocytoma, the child which was being treated with chemotherapy, that showed a cystic tumor. So the cystic tumor usually responds, but it doesn't show that great a response to chemotherapy and may remain stable for many years like that. So that cyst is again an indication of chronicity or a tumor which may not respond optimally to chemotherapy.
Right. Thank you, sir.
Right.
Just to add on a point, I would ask Dr. Feroz over here. Ma'am, when you have a patient presenting to you with absolutely a retinocytoma-like picture, and of course, there is a little bit of doubt of it being like retinoblastoma. When do you take the decision of attempting chemotherapy or do you usually wait and then start chemotherapy? What is your preference?
Thank you for the question, Rolika. In fact, I was going to ask this question to Dr. Seema. So if I have clinical features which is suggestive of a retinocytoma, we do come across in our practice sometimes with, a fish flesh-like in appearance, cystic spaces, chorioretinal atrophy around it, and you might find a sheathed vessel also along with it. Usually, if it is a retinoblastoma, you get a thick feeder vessel. So in the absence of that, if it fits into these clinical pictures, and in fact, they can be vitreous seeds also around, which is usually crenated, not like the regular cloudy spherule kind of vitreous seed, I would observe. So I would put the child on a close observation. I wouldn't jump in for a chemotherapy or a plaque brachytherapy or an IAC and observe the child. Close observation initially. That's what I would do. But then if definitely there is some amount of vascularity, it could be intrinsic vascularity or a feeder vessel which is going through it. It could be a retinoblastoma, but as Dr. Mahesh rightly said, it could be a well-differentiated RB as well. So giving a treatment is wise because we don't want it to progress into, a full-fledged retinoblastoma. Yeah, this is what I would do.
Thank
Yes,
you,
one
ma'am.
other learning point from
Yes.
Dr. Seema's case number 1. So it's a unilateral case, adult, like when it was diagnosed. So unilaterality doesn't mean it's not a germinal retinoblastoma. So unilateral cases can also be germinal retinoblastoma. That's another learning point from what case number 1.
Yeah, absolutely.
Right. And just another question, maybe Dr. Lingam sir can answer that. Sir, do you feel that what is the usual age that you see retinocytoma transforming into retinoblastoma? Any retinocytoma that you've been observing, and then you see a transformation at which usual age?
I just wanted to add one comment before I answer your question straightforward.
Yes, sir.
Is that in addition to the two scenarios which were discussed about retinocytoma, one is representing in the family where there is retinoblastoma in an adult, and second, of course, is a treated tumor which regressed except for the small retinocytoma component which didn't respond. You can also find it as an accidental discovery on a routine examination of even an adult without family historetinoblastoma. Now, that situation, I would think the chances of it converting into a proliferating retinoblastoma would be extremely rare. But in the situation of where you have treated a patient with retinoblastoma and you are left with residual tumor, which you are labeling it as retinocytoma just because it is not responding to chemotherapy, brachytherapy, and whatnot, that may be a mistake because we have had patients who were enucleated long afterwards with a tumor which was not actually enucleated. This was a patient from Bangladesh whom we have operated for vitrectomy because he was stable with the retinocytoma-like residual lesion for about 2 years. And then he developed a rhegmatogenous retinal detachment. There's no tumor proliferation, mind you. So it's only for the RRD we operated. But because we are operating on RRD and there is still some fish flesh appearance, we excised that area and put it for histopathology. It did show still tumor cells. So retinocytoma as a clinical diagnosis doesn't always mean that there are no proliferating tumor cells. So this is in the milieu of a treated retinoblastoma, in the milieu of an adult patient coming with an identified lesion which is looking like a retinocytoma. You're still probably justified in labeling it as retinocytoma, but I wouldn't label a child presenting with a lesion like that as retinocytoma and say I would not do any treatment. A critical follow-up is a must, even if we suspect it is retinocytoma. But I think I would probably err on the side of thinking it is a retinoblastoma than retinocytoma, young child. Does that answer your question, Dr. Rolika?
Yes, sir, absolutely. Thank you so much, sir.
And one
Rolika,
about the case which was presented, enucleation did not show tumor. Were all was the entire extent of tumor examined histopathologically? Usually they may take 3 or 4 samples.
So usually, I think that's what is done. We do a bread loafing, and actually, because we are also surprised, so this was actually reviewed by 2 additional different pathologists also, and there was no evidence of any tumor in the eye. So possibly, was Dr. Santosh was saying that was the final possibility we considered, that possibly a post-plaque retinopathy changes, which suddenly caused mimic the appearance as if the tumor is grown in size.
And one last point is when we're trying to document, of course, we are all taking the fundus photographs and OCTs, but what people tend to forget is to compare the two. Means you see the existing photograph, see the fundus picture or old photograph and the fundus picture. That's not a correct way of really looking for growth. Put the two pictures next to each other and examine them very critically, because including the landmarks of a blood vessel nearby, etc. A small increase in the growth of tumor can be easily missed if we are just seeing very casually the old and new pictures. Thank you.
Right.
Right, so thank you so much. Before we move on to the next talk, I would just like to recall a moment when I just started my fellowship and I asked a question and I asked Dr. Mritika Sen, I said, can you please tell me what exactly retinoblastoma looks like? Because as a resident, I haven't seen it really, what this calcified tumor really looks like. And she gave me the weirdest look anybody could ever give. It's like, you don't even know what retinoblastoma looks like. And from there, she decided to teach me everything about retinoblastoma. And I remember she's walked me through it. And I'm so glad that today we both are at two ends of the country treating retinoblastoma cases. So over to you, Dr. Mritika Sen, for the next case. And I would also invite Dr. Sumit Lahane, sir, for the discussion as well. Over to you.
Thank you, Rolika. I think I still gave a weird look when you introduced me. But anyway.
But the fun part is Ishita asked me the same question.
Yeah. All right. Are my slides visible?
Yes, absolutely.
All right. So I'll be taking you through a track that's called Phthisis in Crisis. So this was a 9-month-old female child who the parents gave a history of a blunt trauma about a month back. And she came to an ophthalmologist with left eye congestion. Anterior chamber showed exudates and heme, and there was posterior synechia. The right fundus was normal, and left eye there was no view. An ultrasound was done, and the ophthalmologist informed the parents of no visual prognosis in that eye, being prethisical following trauma. The child was in fact referred to oculoplasty for cosmetic rehabilitation. Let's fast forward to the presentation to us. This child came back after about 3 months. She was 1 year old, and this was what her clinical picture was. The left eye was phthisical, there was no ciliary tenderness, and fornices were adequate. The parents had come for the cosmetic rehabilitation. But let's rewind back to 3 months before. So we asked the father what exactly happened. So the father said that the trauma was with the child's head while playing. But on asking further, the father gave a clear history of white reflex in the left eye at this age of 6 months, much before the trauma actually happened. And when we asked the parents to show the older pictures, there was some exodeviation of the left eye. So let's just pause and think about it. Is this really a post-traumatic phthisical eye? So we repeated the ultrasound and we looked at the older ultrasound, which was done by the ophthalmologist somewhere else. And we found that there was no clear mass as such, but possible areas of hypoechogenicity, possibly calcification. So as we discussed in the previous cases, it is always good to take an opinion. And I discussed this case with Dr. Lingam Gopal sir, and we went ahead with an MRI along with a CT scan. So these are the MRI pictures which showed a small left globe, and there was a T2 hypointense lesion within the globe and some amount of contour abnormality as well. It was on CT scan, there was some amount of calcification which really did not correspond to a calcification seen in a phthisical eye, and there was diffusion restriction. So at this point, we decided to manage this child with an enucleation with a long optic nerve stump, suspecting a retinoblastoma, which was confirmed on histopathology, which showed a poorly differentiated retinoblastoma with massive choroidal invasion as well as scleral invasion. The bone marrow CSF was negative, fortunately for the child. The child underwent EBRT, and this was with a stalk shell, the photograph. She's completed her EBRT and she's continuing with her adjuvant cycles of chemotherapy. Now, what I want to emphasize here is that it's important to go about with the history again if required, and the parents know best. So ask leading questions to the parents, ask them for photographs even and before planning any sort of intervention for the child. Thisis bulbi is a masquerade for retinoblastoma. It is important, especially in a child, to rule out retinoblastoma with an ultrasound, and if it's not clear on an ultrasound, to resort to imaging in the form of MRI as well as CT scan when required. This is extremely important because we don't want to do anything like an evisceration for in cases with an unsuspected retinoblastoma. And finally, I would also like to emphasize the problems or the morbidity associated with delayed diagnosis of retinoblastoma, which leads to, like in this case, there was extraocular extension, which requires prolonged therapy with radiation as well as high dose chemotherapy. So, thank you very much.
Thank you so much, Dr. Mritika. May I also request Dr. Sumit Lani sir to give his points on the case that Dr. Sen has presented.
Very good evening, everyone. Very nice case by Dr. Mritika. This is very commonly seen in that patient present with the thisis, and we always have a diagnosis of a blind eye. And the cosmetic rehabilitation most of the times is done with the evisceration. So I would like to tell few points that the histopathology is very important, whether you do a enucleation or evisceration, let it be for a cosmetic purpose, let it be for a child or an adult patient. Because histopathology many times tell you the different diagnosis. I had a myself experience with doing a evisceration in a very old age patient, and I found that patient found to have a teratoid medulloepithelioma. So it can happen in any patient. Second, it's very simple. We can make a dictum from here or a thumb rule that never label a pediatric patient as a painful blind eye or end stage without excluding retinoblastoma. Because retinoblastoma, though a rare diagnosis, it could be life-threatening. So it should be taken as a first differential diagnosis when you see in a child a thisis eye or the atrophic bulbi. Second, enucleation should be must. I think evisceration, especially in this age where we do suspect retinoblastoma very highly from the child of 1 month till the child of 6 to 7 years, enucleation I think should be a technique of choice when you want to plan even a cosmetic rehabilitation, especially in such a B scan where there is no calcification, becomes difficult to differentiate between what are you looking at is just a painful blind eye or it is a tumor hiding inside. Second, the imaging is a must. Like she did everything possible. She did ultrasound, she did CT scan, MRI, everything to find out is there any pathology she can find out prior to the surgery. And this has to be correlated with the pathology which we see. Like Dr. Santosh sir has shown very nicely in his presentation that how the histopathology and how the imaging can be correlated very well. And most important, the last point is there has to be a communication between your pathologist and ophthalmologist. If you don't talk to them that what are you suspecting and they miss certain parts, then even with the suspected diagnosis, the pathologist may not find anything because they are not seeing the patient, they are just seeing the samples. And I think drawing a proper diagram, suspecting, giving a differential diagnosis, and whatever excess of information you can give to your pathologist is must in such cases.
You're muted, Rolika.
Sorry, thank you, sir. May I request Dr. Shanmugam sir to please give his pointers as well?
One of the point is to examine the other eye, and what happens is when there is in all these children, because it could be a retinocytoma hiding in the other eye. Second is like usually what happens is the trivial trauma draws the attention of the parents to the eye. So that's when they think that like with the attributed to the trauma, like the case which is presented, to go back to the history to find out like what kind of a trauma it was. If it's just like they'll say head trauma or something like that, it's not a globe rupture in that sense of the word which has resulted in a thisis. So that's something the history is particularly important. And any doubt in a sightless eye, better to enucleate rather than thinking that it is not retinoblastoma and leaving it alone and like putting a cosmetic shell on it. So any doubt, best would be to enucleate and then cosmetically like put a shell on it.
Yes, that's a very important point, sir. Like it's better not to avoid like ignore enucleation in such cases. Dr. Mithika, I have a question for you as well, that because you're a part of a panel as well. So my question is that how often do you see cases of phthisis without retinoblastoma in your practice right now?
That's quite common, especially if you have an oculoplasty busy clinic. Physical eye is quite common, but what we need to remember is that we need to be extra careful in extremes of age group, and we need to have a good history. If there is an adequate, well documented history of the cause of phthisis, then it's okay. But in pediatric age group, we need to keep retinoblastoma in mind as our first differential before we plan any intervention of either observing or just placing a stock shell or even planning evisceration. And as it was discussed, it is always better to plan enucleation when the diagnosis is not clear.
Right, sir.
Can I make a point, Dr. Rodika?
Yes, sir.
Yes, sir.
There's 2 points. One is the presence of physical eye doesn't mean there's no active retinoblastoma. Something
Absolutely, yeah.
beautifully brought out by this case. Just because there was tumor necrosis doesn't mean all tumor has got necrosed. There are still active cells and they've actually invaded the choroid as well. Second thing is not exactly related to leucocoria, but similar to what you find a tumor in a blind eye, you can get in adults a melanoma in a blind eye.
Exactly.
But there's a beautiful article which showed how many eyes of blind eyes have had an incidental finding of melanoma identified. So if you find an adult with a blind eye, it's not anything, it should be a routine to do at least an ultrasound periodically once in a while to make sure it's not harboring a melanoma. Thank you.
Thank you, sir. Absolutely.
And UBM as well, because ultrasound may miss anteriorly.
Anterior lesions.
Especially in children. Children, obviously, even medullary epithelioma can cause atrophy and phthisis.
Thank you. Thank you, everyone. Over to you, Dr. Romta.
Thank you, ma'am. I would now like to invite Dr. Farnaz to share her screen for a case on atypical retinoblastoma. The discussant for this case will be Dr. Feroz PM.
Hi, good evening. My slides are visible?
Yes, Farnaz.
Yes.
Okay. Hi, I'm Dr. Farnaz Yazir. I'll be presenting a case of atypical retinoblastoma, diffuse infiltrating variant. So, we had a 5-year-old male with an alleged history of trauma to the right eye with a ball, and he developed whitish discoloration. The next day, he went to the local ophthalmologist in view of the pseudohypopion with anterior chamber cells and flare. The following in the upcoming slides were done before he presented to us. So this is the ultrasound, which was interpreted to have diffuse homogeneous echoes, partial retinal detachment, choroidal detachment, and the fundus picture that the child walked in was interpreted to have extensive exudation with tortuosity of vessels, neovascularization temporally, and shallow exudative RD. So with this, they had made a differential diagnosis of Coates retinoblastoma or panuveitis, for which the child had already undergone right eye vitreous tap and Ozurdex implant insertion for the control of rapidly progressing inflammation. But to their surprise, the cytopathology revealed small round blue cell tumor, which was malignant. So finally, they referred to us. Now, 3 days after all this, the child presented to us, and the best corrected visual acuity was 6/24. There was no leucocoria. An anterior segment examination had subconjunctival hemorrhage, obviously at the site of Ozurdex implant. The cornea was clear, mid-dilated pupil. Anterior chamber had dispersed seeds extending from the back of the corneal endothelium with cells flared, and there was no ectropion uvea, no neovascularization of iris. The child was subjected to examination under anesthesia. The intraocular pressure was normal. The fundus had a diffuse, predominantly endophytic and patchy infiltrative mass in the temporal quadrant from 6 to 6 to 10 o'clock. And this was associated with diffuse spears, clouds, and dusts of vitreous seeds with epiretinal seeds also on the ciliary processes. Ozurdex implant was found inferiorly, so cryotherapy was done to the port site. So a diagnosis of retinoblastoma, group E with clinical high-risk factors, and stage 3A, accidental, limited orbital disease was made. Bone marrow and CSF staging was done, which was negative. Ultrasound biomicroscopy was done and had no ciliary body invasion. MRI orbits was also done and there were no radiological risk factors. So now the management options for this clinical situation were neoadjuvant standard chemotherapy, 6 cycles followed by focal treatment, or primary extended enucleation followed by histopathology guided adjuvant chemotherapy. In order to attempt eye salvage, we decided to proceed with neoadjuvant standard chemotherapy. So after the first cycle itself, the anterior chamber showed complete regression of the seeds and significant reduction in the tumor size as well. You can find the crumpled Ozurdex implant inferiorly post second cycle of chemotherapy. Post 6 cycles, there was significant reduction in the tumor size and infiltration, and intravitreal high-dose topotecan, 7 doses were given. After the final injection, the child developed vitreous hemorrhage. VH resolution was extremely slow, and then the child was observed for 4 months in order to look for the resolution of VH. But he developed total cataract, and ultimately there was no view of the retina. So we had to go ahead, we decided to go ahead with enucleation with a long optic nerve stump, before which we had done an UBM and it was normal. And MRI also was done, but showed no extraocular extension also. Histopathological examination showed regressed retinoblastoma with complete retinal detachment with no evidence of active tumor in the optic nerve, sclera, choroid, or the anterior chamber. So why should we know about this? So that's the whole point of the lecture as well. Retinoblastoma, the most common primary intraocular childhood malignancy, and India alone contributes to almost 2,000 cases for the annual retinoblastoma cases. So the growth patterns can be endophytic, exophytic, mixed endo or exophytic, and diffuse. So diffuse infiltrating retinoblastoma is a rare growth pattern where the tumor grows horizontally rather than vertically. It's most difficult to diagnose because there is no well-defined retinal mass, and this mimics an inflammatory process. It's mostly unilateral and sporadic in children around 5 to 8 years, unlike the usual retinoblastoma cases, and this itself has a rare variant of diffuse anterior retinoblastoma where a very small focus of intraretinal tumor at the far periphery only, which might not be seen as well at times. It seeds the tumor cells into the aqueous humor from the vitreous base and also to the ciliary body. As a result of all these things, these tumors tend to resemble uveitis, and thereby this is a diagnostic difficulty. Characterized by flat, widespread, diffuse neoplastic infiltration of the retina, but there is dispersion of tumor cells into the anterior chamber and vitreous. The masquerades are mainly as white eye pseudohypopyon, anterior chamber inflammation, iris heterochromia, vitreous cells, intraocular hemorrhage, all of which can suggest uveitis. Furthermore, inadvertent attempts at diagnostic taps, vitreoretinal surgeries, vitrectomy, add risk to tumor dissemination and thereby systemic metastasis. Presenting with unique atypical findings, the diagnosis of diffuse infiltrating retinoblastoma remains a major challenge, particularly when it is difficult to differentiate it from conditions like uveitis and vitreous hemorrhage in children. This is complicated by a higher frequency of high-risk pathological features and metastasis-related death, because of which all the eye care specialists pediatric ophthalmologists, retina specialists, uveitis specialists, ocular oncologists, all of us have to have a high index of suspicion because diseases don't read books and can masquerade as harmless, innocuous pathology, thus delaying diagnosis and resulting in poor outcomes, which can be easily avoided if found earlier. Thanks a lot.
Thank you, Dr. Farnaz, and thank you for that line that diseases don't read books. That's very interesting. Now, I request Dr. Feroz, ma'am, to give her comments on this case.
Yeah, Farnaz, excellent presentation as usual. And thanks for bringing up this case of a diffuse infiltrating RB. So in fact, when we talk about diffuse infiltrating RB, we have all retinoblastoma specialists sitting here. We do see otherwise also in younger children as a part of, endophytic or exophytic, where there is diffuse infiltration, even involving the posterior pole and the posterior retina. But in this particular case, this is where it's far in the periphery. It's more in the peripheral retina which is getting infiltrated. There is also an endophytic component which is again seeping into the anterior chamber. And normally in our practice we come across in children who are of older age group who presents like this rather than the younger children. Of course, as you said, for who is not into seeing these cases which is not textbook printed retinoblastoma, it often becomes a dilemma, as in this particular case where it was thought to be a vitritis or a vitreous condition, inflammation which was treated, but then the feeder vessels again is a giveaway in these situations. So in a case that we had reported, I had actually reported in during my fellowship at Wills, we had a diffuse infiltrating anterior segment retinoblastoma, where you said there can be a foci in the retina, but that particular case didn't even have a foci in the retina. So it was completely infiltrating the anterior segment. And most of these cases are usually present in older children. Now, the question is whether we salvage the eye or we do not salvage the eye. Diffuse infiltrating retinoblastoma, right from the classification, has been, introduced. The international classification, it has been classified under Group E, where it's considered to be advanced. And even anterior segment infiltration earlier was considered to be high risk in pathology, but now with the treatment that we have with intracameral intravitreal topotecan, we try to salvage most of these eyes. We don't jump into enucleation if it is not too much of infiltration, where you can either inject or plaque. The case that we reported, where it was a anterior segment, a nodule sitting in the angle with infiltration of the iris, was treated with plaque brachytherapy and systemic chemotherapy, because there was intervention done, and this child also had intervention done. So it was the right way of going ahead with systemic chemotherapy, also avoiding any metastasis or orbital seeding in this particular case. But yes, unfortunately, it had to be enucleated. So lesson from this is one, it's very important to identify as a differential diagnosis. We were talking about lots of differential diagnosis here. Thorough evaluation when a child comes with any white lesion in the eye, even in the periphery in an older child, you have to look at it 3 times or 10 times to look for all differentiating features, to exclude retinoblastoma. And it's very, very important. A thorough evaluation of the angle with the UBM and the anterior segment is so important whenever you have a white lesion in the periphery of a child, to rule out retinoblastoma before you go and intervene with injections or anything. Yeah. This is how it is. And always look for, even it can present as just anterior, although it is very, very rare and it is reported.
Yes. Thank you so much,
Thank you,
ma'am,
ma'am.
for your pointers. Yes, Mahesh, sir, would you like to give some add-on
A couple
pointers?
of learning points in this case. Same, like the history of trauma draws the attention of the parents to the eye. And if you see the picture, the eye was absolutely quiet. So eye with uveitis, you would expect circumcorneal congestion, conjunctive. Of course, a JRA can present with a quiet eye. And the cells of this hypopyon are larger in cells and they don't shift that easily. That's another pointer. Third is like Dr. Santosh brought out so many beautiful points about differentiating Coats disease from retinoblastoma. One other point is Coats disease doesn't involve the retina. So here you will see full thickness retinal infiltration which obscures the retinal vessels. That would be a retinoblastoma. So that's what you can see here as well. You can see the mass infiltrating the retina and obscuring the retinal vessel. That once again indicates it's not Coats disease, but more likely to be retinoblastoma. And diffuse infiltrating retinoblastomas, despite all our efforts, most often will need an enucleation at the end of it. Thank you.
Thank you, sir. And I think Dr. Sushma ma'am had asked Lingam Gopal sir a question. So could you please answer that question for the audience as well? The question was that can we request LG sir to please give pointers on differentiating chronic RD with changes versus diffuse infiltrative retinoblastoma?
The question was chronic retinal detachment with PVR.
PVR, okay.
How do you differentiate from retinoblastoma? Basically, PVR is a fibrotic process. I think that's what I wanted to emphasize, that an untreated retinoblastoma never causes fibrosis. So if you have a fibrotic lesion, basically, you are probably shifting away from retinoblastoma in all likelihood. And a retinal detachment with PVR is RD with where the retina is crumpled by scar tissue. It is very difficult to confuse it with a diffuse infiltrated retinoblastoma where the entire retina is thickened. And it could still be mobile or maybe partly mobile, but RD with PVR would be almost like a fixed retina which doesn't move because of the severe fibrosis. So if there's a fundus view, there will be no problem in differentiating the two. The problem occurs when there's no fundus view, either because of Post-K or complicated cataract. If once you lose fundus view, then the ultrasonography can become very critical, wherein it's important that you don't rely upon an ultrasonography done by X, Y, or Z, but you do it yourself, because that is the only critical evidence you have in this case to differentiate from diffuse infiltrated retinoblastoma.
Can I add another point, sir?
Yes, please go ahead.
Diffuse infiltrating may also have a commonly rubeosis iridis with secondary glaucoma, and RD with PVR, despite even if there is anti-halide proliferation, may have rubeosis, but like they usually don't have very high pressures or secondary glaucoma.
Yes,
And
ma'am.
Rolika, one more point in this while examining, when the child comes in, when there is a peripheral lesion like this, we always talk about 360-degree aura examination. With a good indentation, we can even go to the ciliary body. So whenever you have a lesion like this, which is sitting in the periphery, it is good to really go inside and see whether there is any deposits. Although this looks very retinal infiltrative, the child had an anterior segment infiltration. So there should be some ciliary body seeds sitting in there and infiltration sitting in there. So as an examiner, as a retinoblastoma specialist, we should always go beyond the aura in these particular cases and check.
So there was ciliary process frosting in this patient, and we do routine UBM 360 degree in all these patients because there are two types of seeds. One are the depository seeds, which simply walk through the zonules and come into the anterior chamber and sit there. The second are infiltrative, where there is contiguous extension to the ciliary body, iris, trabecular meshwork, and then they come into the anterior chamber. The infiltrative are the ones which ultimately come to enucleation. I have not been able to save any of these eyes except one, whereas the depository ones are nearly always salvageable.
Yeah.
Rolika, I just wanted to add one more point that very rarely it can present with vitreous hemorrhage also. So I think MPS sir must have known, we have discussed about this case. So history of trauma, vitreous hemorrhage, P scan showing, chronic detachment like picture. It's very, very, very difficult to differentiate it from and PL positive. It's a very dilemmatous situation where to decide what to lean towards to. So yeah, vitreous hemorrhage is something which it can present with also.
Thank you, ma'am. Thank you. So
interesting case.
There's just one more point I'd like to add, that in the middle of a quiet eye, Mahesh did refer to the GRA having a quiet eye. The other condition, which is little more bordering on retinoblastoma-like presentation, although it can be easily differentiated, is a pars planitis. And in pars planitis, what can happen is you can have vitreous balls of exudate right in the 6 o'clock meridian, which could almost mimic a vitreous seed of a retinoblastoma. And the differentiating point, of course, is presence of keratic precipitates, which is most often seen when you have those vitreous exudates in a pars planatis. And when you indent, you actually don't see any lesion in the retina itself. And these are sitting on top of the retina. They're not arising from the retina. So this can be easily differentiated. But just a point to concern, point of concern that when you examine, don't get carried away by any one finding, but put everything together before you come to a conclusion.
Sir, good point. Can I ask you a question, sir?
Yeah, please.
Yeah. So how common is pars planitis in a child?
Very, very common.
Okay.
Even a three-year-old, 4-year-old child can have pars planitis. In fact, we have diagnosed it only under GA because the patient didn't allow proper examination under GA. We found the pars planitis and then asked the uveitis people to come in and start treatment for the child. So pars planitis in children is pretty common, not at all uncommon.
We actually had a case during my fellowship, if Dr. Hanava remembers. We had just pars planitis and no other presentation, no other lesion, which presented similarly. Dr. Hanava, if you recall. We treated with corticosteroids and it absolutely resolved. Okay, so moving on to our next case, it would be the Coats disease case by Dr. Ashwita Alva. And I request Dr. Mangat Dogra sir to be here for the discussion. Over to you, Ashwita.
Is my presentation visible?
Yes.
Very good evening, everyone. I'm Dr. Ashwita Alva from Center for Sight, Hyderabad. Thank you very much for this opportunity, and let's dive into walk-in patient with leucocoria, where I'll be discussing about two cases. The case number one is of a 3-year-old male who presented to us with the white reflex in the right eye since 1 year. He was referred to us with a suspicion of retinoblastoma in the right eye. However, there was no family history of retinoblastoma. There was poor fixation in the right eye and the child resented closure of the normal left eye. On anterior segment evaluation, there was clear cornea with yellowish orange pupillary reflex suggestive of xanthocoria. There was no iris neovascularization and the intraocular pressure was normal. Left eye anterior and posterior segment examination was absolutely normal. The fundus examination showed an exudative retinal detachment with peripheral telangiectasia and large retinal macrocyst, which was suggestive of probably a chronic retinal detachment. And dense, diffuse intraretinal and subretinal exudates were seen in all the quadrants. Clinically, we diagnosed him to have right eye Coats disease with stage 3A2. We went ahead to do a CT scan. This is an axial section showing a thin solid component. However, no obvious mass was seen. There was no calcification on the CT scan, and this consolidated our diagnosis. This is an image in the mid-treatment cycle where we treated the patient with transpupillary thermotherapy with a power of 500 milliwatt, lasering all the telangiectatic vessels. Cryotherapy by double freeze thaw cryo was done to the peripheral vessels, especially the ones on the areas of subtotal retinal detachment. Adjuvant treatment was done with right eye intravitreal injection of ranibizumab given at a dose of 3 monthly intervals in view of the diffuse exudates and telangiectasia that we appreciate. The patient had an excellent response showing settling down of retinal detachment, complete resolution of the retinal macrocyst, and significant reduction in the retinal telangiectasia. The diffuse retinal exudate settled down to refractile focal exudates. This was an image about a year later where there is drastic reduction in the subretinal exudates. However, the vascular lesion in an inferotemporal quadrant was seen, suggestive of vasoproliferative lesion. This was further treated with triple freeze thaw cryotherapy. The second case is slightly more challenging. This is a 4-year-old male presenting with left eye redness, severe pain since 10 days. On examination, he had both upper and lower lid edema, and xanthocoria-like picture was also seen in this patient. Circumcorneal congestion was seen, and microcystic epithelial edema was seen. Neovascularization of iris was appreciated in 2 clock hours with the diffuse ectropion UVA. Intraocular pressure was elevated and found to be 40 millimeters of mercury on Perkins tonometer. Fundus evaluation showed a bullous exudative retinal detachment with peripheral retinal telangiectasia in more than 3 quadrants. Diffuse intra and subretinal exudates were seen. A yellow subretinal hue in the inferotemporal quadrant was visualized. However, no clear intraocular mass was seen. Bulbous retinal terminal configuration of these retinal vessels gave an appearance of a light bulb telangiectasia. We went ahead to do ultrasonography. As expected. Dense hyperechoic vitreous membrane suggestive of retinal detachment was seen, and an echo-dense subretinal nodule, which was also seen in the fundus image in the inferotemporal quadrant, was visualized. On a radiograph MRI scan, the T1 showed a hyperintense lesion and T2 showed two well-defined nodular iso to hypointense lesions. The radiologist also suspected a retrolaminar extension of 2.7 mm. There was no evidence of retinal or optic nerve head calcification on CT screening. So thus the radiologist expressed to us his concern regarding the possibility of retinoblastoma as well. Clinically, he was diagnosed with stage 4 Coates disease with retinal detachment and neovascular glaucoma. Possibility of an atypical retinoblastoma with tumor necrosis and neovascular glaucoma was also considered. However, since the child had no potential for vision and was severely symptomatic with raised intraocular pressure, the treatment option was discussed with the family and he underwent left eye enucleation by minimal manipulation myoconjunctival technique with an implant. This is a histopathology image of it showing a funnel-shaped retinal detachment and classical signs of Coates disease with dilated vessel with RBCs within the lumen. Cholesterol-like clefts and foci of amorphous calcific deposits were also visualized. In addition, hemosiderophages were also seen in this patient. Going back to the history, George Coates was the first who described way back in 1908 as a developmental retinal vascular anomaly consisting of leaking telangiectatic and aneurysmal retinal vessels with associated lipid exudation, which frequently occurs in one eye, otherwise in healthy boys in the first decade of life. Dr. Shields gives a classification for Coates based on the telangiectasia, exudation, and the retinal detachment. There are an array of options for treatment in patients who have only telangiectasia with little or no exudation and not threatening the vision. Observation would be preferred. However, treatment must be initiated if progression is noted in any of these changes. Laser therapy with transpupillary therapy or photocoagulation to the telangiectatic vessels and extramacular exudation is preferred. In patients who have peripheral retinal telangiectasia, especially with vessels over the subretinal fluid or subtotal retinal detachment, freeze-thaw cryotherapy with scleral indentation is preferred at an interval of 4 to 6 weeks. Intravitreal anti-VEGF injection is given as an adjuvant therapy to the above management protocols. Where telangiectasia is seen in multiple quadrants, there is dense subretinal exudation or any amount of macular exudation is seen. This is usually given at an interval of 3 months, and we subsequently see regression of abnormal vessels, resolution of the macular edema, and improvement of the vision. SRF drainage or vitreoretinal surgery with silicone oil injection is done in patients with extensive retinal detachment, where simultaneous laser or cryotherapy can be done to the abnormal vasculature. And like our patient number 2, with patients who had elevated intraocular pressure with iris neovascularization or a painful blind eye with an end-stage Coates disease, enucleation with implant would be best preferred. Thank you.
Thank you so much, Dr. Ashwita. May I request Magad sir? Yes, sir.
Thank you, Ashwita, for presenting excellent cases and which we encounter very often. And what I would like to say first regarding your cases, the first one, which you presented and very well managed. I think one lesson which all of us must take from this is that all Coates disease cases, once we diagnose and they are typical, they need to be treated. You see, most of them are progressive. There's nothing, I have not seen that they remain stationary. Most would progress and ultimately land into the subsequent stages. So if you treat them when they are in early stage, say telangiectasia, some little exudation, you can very well treat with laser and you will give an excellent result in them. And also if there is a little fluid there, that is where you first give the anti-VEGF and then you can do even laser in them. We have done in several cases that. And of course, if the fluid still remains, you can do combination therapy with laser as well as doing a cryotherapy to some of the lesions where you have a fluid. And I think the diagnostic dilemma, what has been discussed, I come from an era, I think Gopal is here, LG, he knows. We used to have a collaboration direct with AFIP. Our samples would go from PGI, our Professor Jain, who was our teacher, and it used to be Lawrence E. Zimmerman himself reporting those cases. We had several cases where it would come coarse disease, and because that time the enucleation was the only treatment. So you see, of course, we have evolved. We don't enucleate now because that time only the enucleation was done. So I think we learn a lot, especially once they are subjected to histopathology, and then you realize that where we are. And what also was taught in the next case, the advanced case where I think Ashwita did mention, I think these days even the drainage from outside, if you do it, you need not inject silicone oil. I think somehow Simar Jeet Singh, who's used to work with me, is in PGI Associate Professor. He's now good number of cases where he has done from external approach as well as internal approach. So you don't need a oil, and you can also subject them partly to a cryo once you have drained them. I think they do very well, because the problem here is you don't want to go for enucleation. You want to salvage these eyes even if they have gone beyond. So that is the point which is very, very important. Otherwise, you'll have a painful blind eye. They'll go into phthisis and so many situations. Because I think this topic has been covered very well even by Dr. Santosh as far as the differential diagnosis was concerned, and the treatment part has been very well covered. I think this is something which need treatment. We have had several cases where we somehow we were keen, but patient was reluctant, and suddenly you find the whole exudates are coming to the macula, to the disc. But even if you treat at that stage, give anti-VEGF, do treatment, what I said, with laser or a combination, they tend to regress, and you'll have still a useful, but always, I would say, they need definite treatment. And this classification by Shield definitely help us, which was given way back probably in 2000 or 2001, is still stands for us, and we can treat them according to it, what stage they have come to us.
Thank you, sir. Thank you, Ashwita, for truly covering it so perfectly. And as sir has stated, I would just like to add that Shield's classification did undergo a modification, which Dr. Mritika has mentioned in her review on Coats disease, that it has been divided now, 2B has been divided now into 2B1 and 2B2. And that is of the presence or absence of the subfoveal nodule. So, Dr. Mritika, my question to you would be that in cases with subfoveal nodule that you've mentioned, that even in CT there will be 20% cases which will have calcification, and it has a very similar picture to retinoblastoma. How often do you see these cases?
Thanks, Rolika, for the question. It's not just cases of subfoveal nodule which can have calcification seen on CT scan. These are overall about 20% cases of Coats, and these are usually very advanced stages of Coats. If you can see subfoveal nodule, it's actually very easy to differentiate Coats and retinoblastoma, because that subfoveal nodule of Coats is characteristically made up of exudates, and the problem happens, and when you're actually doing the CT scan to differentiate it, is when the view is not that great, or it is an advanced Coats with extensive exudative retinal detachment, and that is one thing. Yeah.
Thank you so much. Mahesh
This
sir, any comments? Yes, sir.
in the macro area is very common. This is not uncommon in Coats disease cases.
Yes.
In fact, this is something which we find is one problem which we find right in the beginning. So visually they'll not do great, but you can definitely differentiate, and you can be confident if you examine them thoroughly that no, this is not a retinoblastoma, but it's Coats disease. So that is
Absolutely. So the fundus evaluation is very, very important, especially like even if you have a child in the OPD, at least the posterior pole you can see before you plan an examination under anesthesia for the periphery. And also the calcification in Coats is, as sir mentioned, would involve the Coats, along the Coats. and not an intraocular spectral calcification of retinoblastoma.
Okay, thank you
Yeah,
so much.
despite all the clarifications made, coats can sometimes, or retinoblastoma can present like coats as well. It can show some coats like vascular malformations, and select situations like the case number 2, that can be extremely difficult to differentiate the two, in which case like probably it's better to enucleate the eye rather than it a sightless eye rather than try attempting subretinal fluid drainage. So that's something which can be done. And I have pretty much given up doing cryotherapy. Laser photocoagulation is particularly a green laser with a laser indirect ophthalmoscope is adequate enough even in the periphery, because we are not looking at the RPE to absorb the laser energy here. It's the hemoglobin in the vessels which need to absorb the laser energy. So even if it's an elevated lesion overlying the bullous retinal detachment, the laser is adequate enough. And I find that like steroids work quite well as well. If in case it doesn't respond to anti-VEGF, the intravitreal steroids also work pretty well in Coats disease. And I hardly do vitrectomy because the vitreous adhesions in Coats can be very, very difficult to peel, particularly if there is areas of subretinal gliosis or cystic spaces. So transcleral needle drainage with intravitreal injection of fluid will pretty much reattach the retina, and intravitreal steroid and laser is adequate enough in most of the cases with the exudative retinal detachment, which is reaching even up to the lens. In those situations, it's particularly difficult to do a vitrectomy as well.
Right. Yes,
Can I make 2
Divyansh, sir.
points? One point is that the series of Zimmerman, the most common diagnosis of a pseudoretinoblastoma was Coats disease in histopathologically. So obviously many experienced surgeons have made a mistake of confusing Coats disease with retinoblastoma and enucleated the eye. Second point is that as Dr. Mahesh explained, you drain fluid externally and inject fluid into the vitreous cavity either by AC maintainer or through the pars plana, depending upon how much space you have. And once the retina is relatively flattened, you can never flatten the retina completely. So what I would do is put a chandelier and drain the fluid so that, and infused also, so that the retina is settled. Go with endolaser probe through the same port through which we put an infusion cannula and treat the lesions directly under chandelier visualization, because my advantage is that you can actually ablate each one of the vascular malformations despite fluid being there under the retina. With indirect laser, sometimes you may not be able to get proper burns in elevated retina, even if you use yellow laser or green laser, although they are supposed to be absorbed by hemoglobin. But a relatively flattened retina, if you go with the endolaser probe, you can actually treat it very nicely and you get excellent results. Thank you.
What Dr. LG is saying is like, don't do a vitrectomy, but use the port to do the laser. So we do this as well.
Right. Yes, Divyansh, sir.
Oh, sure. So many things have been added for the core disease. Very important to understand that the Shields article has also suggested that there is at least 10 to 12% of cases where it can be an atypical presentation, not in boys, but it can be in girls. And when it's present in girls, there can be a bilateral presentation, and very, very rarely there can be a systemic association also. So just to keep in mind that disease does not read books, and you can have that kind of rare presentations too.
Coats in girls can present at a much younger age, even in 6 months or even lesser than that also you can have Coats disease.
Right. Yes, over to you, Ishita.
Thank you, ma'am. Thank you, everyone, for that discussion. I would like to now invite Dr. Harshita to please share her screen and take us through the last but not the least case on persistent fetal vasculature. And Dr. Divyansh Mishra will be the discussant for this case.
Hi everyone, am I audible?
Yes.
Just okay. Yeah. So good evening everyone. I'm the last speaker, so I'll be presenting my case series of sorts on persistent fetal vasculature or persistent hyperplastic primary vitreous. So a brief overview about the disease. Basically, it occurs due to a developmental malformation due to failure of hyaloid vasculature to regress in the uterus. Based upon what part of the vasculature is remnant, it can be anterior, posterior, or combined types. Most commonly, it presents as microphthalmus or leucocoria. but can also present as glaucoma, cataract, corneal opacities, and retinal detachment also. It also has syndromic associations like neurofibromatosis, trisomy 13, 15, Norie's disease, and also has been seen to be related to Axenfeld-Rieger syndrome, Peters anomaly. It has also been shown to have an association with the ATOH7 gene. The goals of treatment in PFV mainly are visual improvement, reduction of complications like glaucoma, glow preservation in advanced cases, and a good cosmetic appearance. So beginning with the case series, the first case was a 12-year-old male child who presented with counting fingers vision, and mother noticed a white reflex in the right eye. The left eye was absolutely normal. As the anterior segment picture here shows, there was a lenticular opacity which was seen obscuring the pupillary area. Upon doing an ultrasound scan, we can clearly see a hyperreflective stalk-like lesion, which can be seen arising from the disc and is reaching towards the posterior surface of the lens. Now, this was a unilateral PFV of posterior type. Given the fact that it was obscuring the pupillary axis, the patient was taken up for surgery. This is the intraop still, which shows after pars plana lensectomy. After removing the lens and going on to the posterior, placing the biome, we can see that a stalk, fibrovascular stalk arising from the disc with the scarring at the base is seen here. PVD was induced, and along with that, the PVD was induced up to the stalk. However, the surrounding retina was seen to be attached. So just the trimming of the stalk was not really trimmed. It was just released from the lens capsule, and the eye was closed in saline. Now, learning points from this case being how the child was a 12-year-old male. So, despite the age, we should approach these cases with a high risk of suspicion, even when the age is a little bit atypical. Surgical indication usually is a visually significant cataract. But the counseling for the parents is most important, that however we are going to be doing a surgery, but the chances of visual recovery are going to be very minimal due to the dense amblyopia which has already been set. Another surgical point is PVD induction in such cases should be done as much as along the stalk and as much as safely possible. Going on to the second case, this was a young male child who presented with hand movement vision in the left eye and a cataractus lens. It was diagnosed as a unilateral posterior PFV with retinal detachment. Pars plana lensectomy was performed, and after that, upon going on to the posterior part of the surgery, there was a retinal detachment which was noted. So PVD was induced along the stalk and retina and in the periphery as well. But as I already discussed, the vitreous is very adherent in such cases. So IVTA was injected and PFCL assisted PVD induction was done. So learning points from this case mainly that PFV can present with the complications like retinal detachment also. PVD induction in such cases is a major challenge. Another point is the management of the stalk. Now anterior and posterior have to be managed separately. Anterior along with the lensectomy part and posterior along with the vitrectomy needs to be managed separately. Moving on to the next case. Herein we can see a patient where you can see that there's a nasal corneal involvement with pars and downgrowth. There's an angle dysgenesis and elongated ciliary processes. I'm not sure if it was, yeah. Here, elongated ciliary processes are seen, and there's a thick retrolental tissue, which has been noted. The main learning point is in combined types and even in anterior types, there can be anterior segment involvement, as can be seen here. The next case, a young child presented with a white reflex in both eyes. Upon examination, both eyes had a sectoral cataract, and on the posterior segment examination, there was a stalk extending from the disc to the lens. However, the central pupillary area was clear in this patient. So the patient was managed by conservative management, that is observation only. Learning points from this case, when the media is clear or the cataract is not visually significant, we can observe such patients also. Another thing is that however rare it may be, but PFV can also be bilateral, and usually it's reported in less than 10% of the cases. Additional investigations such as CT and MRI need to be done in such patients to rule out the other sinister causes or differentials of leucocoria like retinoblastoma. And systemic evaluation needs to be considered in such patients to rule out syndromic associations. Now, the last case, this was a very recently the parents noticing left eye was showing esotropia with a white reflex and cataract. The right eye was absolutely normal. Upon doing a B scan, we noted a thick fibrous sort of a hyperechogenic stalk-like and high reflective membranes, which were noted arising from the disc and going anteriorly towards the lens capsule. If you can see here, even the axial length was smaller, which was about 14 mm. Now, this child was diagnosed to have a left eye cataract with a proliferative TRD nasally, which is another advanced presentation of PFV. The parents were counseled that the prognosis is not very good, so nil visual prognosis was explained. However, it was planned to take up the child for examination under anesthesia. Learning points from this case is mainly differentiating such children who present with the preterm history of having a premature birth and low birth weight to differentiate it from ROP and FEVR. For this, you need to look at the other eye status and other birth history factors, like this child had a normal birth weight. There was no history of any oxygen supplementation or NICU admission. Another thing, the prognosis has to be clearly explained to the parents very, very properly. Moving towards the end, key takeaway points basically when to suspect PFV, now when to treat and observe. As I already explained, when it is a visually significant opacity which can be seen, so to remove the lens, or if while doing lensectomy we notice that there's a retinal detachment in the posterior segment, then early versus late presentation is important because patients who present early and are treated early tend to have a good prognosis, as the amblyopia would not have set in by then. Another thing is the laterality. Unilateral and anterior types have been known to have a good prognosis, but the bilateral and the posterior or combined types have been known to have a worse prognosis than good ones. Thank you.
May I request the answer to take the discussion forward, please?
Yeah, thanks, Harshita. It was a very nice bouquet of presentations of different type of anterior, posterior, and a combination of PFV. So, uh, uh, some takeaways which I usually, when I see this patients, is very important to counsel the parents regarding the prognosis, because not that your surgery is going to make a lot of difference in the vision, because as we know, it may already have a very dense amblyopia where treating would be very difficult even after our rehabilitation in any ways. Probably the discussion would be open for the stalwarts like Mahesh sir or LG sir and others also. But the answer is, in this case, most of the time the presentation is unilateral and the other eye may be normal. So very important is to differentiate whether we are able to find that other eye is having any other differentials like ROP or an fever kind of an association. And if that is not there, then better to observe. And as we were discussing that cataract, because most of it would be associated with cataract, and if cataract is non-center involving or non-visually significant, again observation would be a better answer. Just a small tip for the surgeons when they are operating, not to try to go and dissect into the stalk, because that's where the retinal tissue would be there, and if we injure the major blood vessels inside, there may be very torrential bleeding and that would create more issues. So just identify where the connection between the cataract and the stalk is there and cut and leave it, and don't try to keep dissecting into the stalk, because it's not going to help us to dissect the retina out of it. So that's it from my side. I think Dr. Mangat sir would also be able to help us give some more pointers to this. But thank you again.
Yes, over to you,
would
Mangat.
like to, yeah. I would like to specially answer what Sushma has asked, and Dr. Mahesh has partly answered. I think we have with us Professor Jagatram, who has done a lot of lenses in these cases, persistent fetal vasculature, where the eye is not really too small. He has a technique where he would like to cauterize it all around because it's a vascularized membrane, and then cauterized also the stalk, and just after cauterizing, cut it. And he has shown very good results with this kind of a limited approach. So, and the number of cases, I think he has significant number now where he has implanted the lens. So that is what would answer Sushma's question also, as well as if the eye is not too small. You see, the question is once it is marginally, maybe just as already mentioned, that it is maybe 0.5 or maybe somewhat there 0.75, then it is possible, which he has shown. So that is what I wanted to, and because I think here again, as mentioned for Coats disease, the minimal we do, better we are. So because I think, and earliest we approach, we are in a much better way to manage these cases.
Great. Thank you, sir. Lingam, sir, would you like to add some pointers as well?
I think the spectrum can be quite wide, in the sense you may have just one stalk of tissue attached to the posterior lens surface with the posterior polar cataract, where of course fairly straightforward, you just aspirate the lens, maybe leave the capsular rim and use a secondary IOL or put IOL at the same time. If the anti-segment surgeons are doing the surgery, sometimes when they cut the posterior capsule deliberately, like a Rexis, and the stalk is left behind and it sort of falls back and then starts bleeding, then they sort of panic. So it's best that you cauterize first and then you cut. Means you can always introduce the cautery through the posterior capsulotomy into the GS and cauterize the stalk first, and then trim it a little bit so that it falls back. You don't have to really trim it all the way up to the optic disc. But if you're a posterior segment surgeon doing the same job, no problem. You add a third port into the anterior chamber itself, and through the pupil, you can actually introduce the light pipe and do whatever you want in the posterior segment and trim the stalk right up to the disc or a little closer, and then cauterize the tip even after cutting it. The second point is that you can have also the typical presentation of PHPV of a retrolental fibroplasia, wherein the posterior segment actually is okay on ultrasound, and that those cases do extraordinarily well, although they look pretty bad when you see from the front. And the way to manage it, of course, is remove the entire lens, including the capsule, and cut the fibrous tissue starting at the ciliary processes, not in the center, because it is a stalk which comes from the center and spreads outwards towards the ciliary process. That's a typical difference between an ROP kind of vascularized membrane behind the lens and a PHPV kind of retrolental fibroplasia, where the blood vessels start from the center and go to the periphery in PHPV, versus in ROP, it starts from periphery to center. Now, when you find that, you must cut the tissue right at the junction between the ciliary process and the fibrous tissue. You know, the ciliary process are drawn inwards and they're visible to you actually. And once you cut there, you actually find there's a empty vitreous cavity behind it. And it's very quickly, you can just cut it all around 360 degrees towards 12 o'clock meridian, nibble it, and then finish the surgery. They do extraordinary. In fact, there's one child who presented at birth with such a small eye that the treating surgeon said it's best to put a cosmetic shell and leave it. But I did this kind of surgery, and the eyeball grew enough to give 660 vision for the child at the age of 4 or 5 years. So these are things which are salvageable. Thank you.
Thank you so
I
much,
think
sir.
what Paul said,
One more point.
true. That is
Yes,
what, in fact, what Dr. Jagatram is doing after cauterizing all around. He's cutting it with the scissor all around because it is so vascularized. And then only he's able to put the lens. So in such a situation, what he also described, I think it is possible and it has been shown. And also making an opening in the posterior capsule, cauterizing it, and just cutting the stalk. It falls back in many situations. That is what he has shown. So exactly what Gopal was also trying to say. I think some of these cases have more of anterior vascularized kind of a process going on, which does very well if we do that kind of approach. Yes.
Thank you, sir.
About it, not all the time you will find the stalk coming from the disc to the lens and all around empty space or the empty vitreous. Particularly bilateral cases, one eye is microphthalmic. The other eye, actually, the retinal fold can come along the nasal side. So there can be a retinal detachment extending from the disc nasally up to the lens. So if you were to place a sclerotomy on the nasal side, you'll be going through the retina. So you need to be aware of that bilateral cases, in which case most of the surgery would have to be done through the limbal incision rather than putting a sclerotomy. So extremely small eyes, bilaterality, need to assume that the retinal detachment can be extending in the periphery. And again, like not that all of these will have poor prognosis, like Dr. Dogra was mentioning. Dr. Jagataram puts lenses, and I remember one particular child where the mother was told to put contact lens. She religiously used a contact lens in a small eye, with the other eye being normal, resulting in a vision of around 618. So that's what persisted. So it's up to the parents for rehabilitation, and of course, if it's wherever possible, we can put the lens as well.
I agree with you that in every PHPV, entry should be at the limbus, not behind the iris, because you can never be sure that there's no peripheral RD. So I always go to the limbus in these cases.
Just wanted to ask one more point. The reason why I asked about IOLs were if we leave them a fake kick, the secondary glaucoma is an actual real problem in especially PFV cases. I just wanted to ask how you would have managed and how many cases have you seen secondary glaucoma in cases which you have operated left a faking. So that is one thing which I have learned, that wherever possible, put the IOL in the primary setting. It really helps, even if not visually, but anatomically, it prevents a lot of complication which is caused by aphakia.
Thank you, everyone. Thank you for all the pointers. And I would just like take the permission to share my screen. And I know that we have kind of exceeded the timeline, but I think we've had great discussions and we have no regrets of waiting this long. I hope my screen is visible.
Not yet.
Loading, ma'am.
Is it visible now?
Yes. Not how it is.
Yes. So first of all, I would like to thank my mentors, Dr. Santosh Honavar sir and Dr. Carol Shields, for teaching me everything about retinoblastoma, and along with the input of all the seniors that I've had. And thank you, Dr. Honavar, for considering me to draft this program for Leucocoria. And thank you also to Dr. Ishita for being my partner in crime, for initiating this entire setup up here in North and at Mahatma Gandhi Medical College. So when we talk about leukocoria, I'll be talking about busting the myths associated with leukocoria. And it's just a brief summary of what everybody has discussed. So myth 1 is leukocoria is always a sign of retinoblastoma. And I think that we have covered it royally and everybody has given their entire differentials. So please make sure that you have every differential in mind. Just to summarize, all of these do look like retinoblastoma, and they are. And all of these do look like retinoblastoma, but they are not. Only one is retinoblastoma. And this is technically Coates disease, which was discussed at length as the commonest. And it has been stated in the paper by Shields et al. As well. And it says that the commonest pseudoretinoblastoma include Coates disease, persistent fetal vasculature, and vitreous hemorrhage. And I'm glad that we have covered that entirely for the audience. And the next option is persistent fetal vasculature, as discussed. And we also have familial exudative vitreoretinopathy as one of the differentials, rhegmatogenous retinal detachment. And the ones that we have not discussed at depth would be coloboma and medulloepithelioma, which Dr. Honavar had also mentioned. So this is just a brief summary. And the second myth is not every congenital dense cataract requires a B scan. And you will be surprised as to how many people believe in that. It's absolutely a myth. Please do a B scan as a mandatory thing. Do not estimate the IOL. A lot of people have a standard IOL power to calculate and keep it ready when they're proceeding with the cataract surgery for these patients. Please follow the rules that have been discussed over here. Follow the entire imaging, rule out every diagnosis, and then think about doing a cataract surgery. Do not open such globes. That would be myth 2. The next would be myth is leukocoria in one eye refers to unilateral disease. No, it doesn't. It absolutely does not. We had a case like this in which there's a small lesion in the other eye, which is seen in the periphery, and that is a group A case. So no, it does not refer to unilateral disease. The next myth will be that leukocoria can only be detected in advanced stages of retinoblastoma. Even that's incorrect. This is a case of stage B, seed in the macular region, and because it's in macular region, that is why the leukocoria was evident. So it's all about where the location is. Sometimes even the ones in the periphery can be seen if they're good enough for size. Then the last myth is leukocoria can be observed, an absolute no. And I thank the panel for making sure that everybody knows that. And thank you very much. This was just a brief summary that I wanted to keep. Thank you everyone for coming together and helping in busting these myths. Thank you very much. And I request our chairpersons, Dr. Mahesh Shanmugam sir and Dr. Lingam Gopal sir, to please give their vote of thanks.
You want us to give vote of thanks, or you want us to
Closing remarks, sir. Sorry.
All right. So basically, I think most of the points have been very well covered. Just to summarize, some of them will be repetitions, but it's better to emphasize certain points which could sometimes slip our attention when we listen to a whole webinar. One is, when you see a leukocoria, it's almost like retinoblastoma versus the rest. Means you know that life saving is much more important than eye saving. So retinoblastoma should be first excluded, and that's very, very vital. We're not saying all leukocoria are retinoblastoma, but you assume that it could be retinoblastoma, and we want to exclude it first before you consider other differentials. History of prematurity would be a guiding force in trying to look at the appropriate causes of leukocoria. Family history would be important. Age at presentation would be important. Now, when you examine the eye, presence of fibrosis in an untreated eye is very much militating against retinoblastoma. This is fundamental because retinoblastoma is a tumorous mass. It does not produce gliosis as a first reaction. It produces secondary adenode out. It can produce a tumor mass. It can produce vascular malformation, similar to coats sometimes, but it does not produce fibrosis unless it has been treated with cryo or brachy or some other modality. Coats disease is yellowish, fibrosis is whitish, while retinoblastoma is creamy white. A person who has seen one of these three conditions at least once in their lifetime can easily diagnose it. Next time there won't be any confusion between the two. I don't think anybody would mistake a fibrotic retrolental fibroplasia with a retinoblastoma. Fibrosis again pulls the ciliary process towards you, center, while retinoblastoma pushes them away. Hence, if ciliary processes are visible to you easily, is more likely you're dealing with a fibrotic lesion. Some misleading signs or a premature child, developing a retinoblastoma. Sometimes on ROP screening, you detect a retinoblastoma. So prematurity does not mean retinoblastoma cannot occur. Same way, retinoblastoma in a microphthalmic eye. Although microphthalmia is said to be having, RB in a microphthalmia is relatively low, it can still happen. A diffuse inflated retinoblastoma has been extensively discussed. I won't go into the detail. Same way, a retinoblastoma can still be present in a painful eye, painful blind eye. Although retinoblastoma in general is quiet, doesn't cause too much of pain. And calcification can occur in Coats disease, doesn't mean it can have to be retinoblastoma always. I think these are some of the points that I wanted to cover before we conclude. Thank you very much.
Thank you, sir. Mahesh, sir, over to you.
Like Dr. LG summarized it very extremely well. Just a couple of points, just like they mentioned, disease doesn't read textbooks, so there can be overlap. So even in PFVIs can have retinoblastomas, and what looks like Coats disease can also be retinoblastomas, because retinoblastoma can present like a Coats-like appearance. And never disregard the parent's complaint. So it's usually the parent, the mother, or the close relative who picks up the leukocoria. And very often we find that the ophthalmologist doesn't dilate the pupil and just looks at the eye and then says everything is all right. You come back 1 year later, and 1 year later the child comes with a group B retinoblastoma. So whenever the parents complain about it, because like the particular angle, the white reflex, the leukocoria may be obvious, which may not be obvious to us when we look at it in the OPD with the undilated pupil. So when the parents complain of a white reflex, always dilate the pupil and see. If any doubt, best would be to do a J exam. That would be my last comment. Thank you so much for a wonderful webinar. I congratulate all the speakers and for Dr. Santosh and Rolika for putting up such a great webinar. And every case was a learning point, and every discussion was absolutely marvelous. Thank you so much for the wonderful webinar.
Thank you so much.
Thank you so much. Thank you.
Thank you. Thank you everyone for taking your time out on a special Saturday. And I thank everyone for sharing their pointers for the general population as well as the specialists. Everybody has literally enjoyed listening to these conversations, and I personally consider this topic very close to my heart. And thank you everyone and the audience for coming and seeing the lecture. And thanks everyone on behalf of AIOS and Dr. Santosh Honavar. Thank you. Can I request everybody to just come
Thank
on screen for once and we just take a screenshot?
You want us to smile?
Yes. Thank you. Thank you, everyone.
Thank you,
Have a
everyone.
great
Have a
day.
good
Thank
night.
Thank you all. Good
Have a
night.
good night.
Bye.
Yeah, thank you so much.
Good night. Good
Thank
night.
you.
Good night.
Good night.